Vidya, can you switch on your video, please?
Now I'm switching on my video.
Vidya Chaudhary.
Good afternoon, ma'am.
Good afternoon. अनुपम लास्ट टाइम ज्वाइन कर रही हो बिल्कुल, तुम बिल्कुल लास्ट मिनट.
मैम मेरे नेटवर्क के साथ प्रॉब्लम हो गया था इसीलिए.
ओके. विद्या चौधरी
कर रहे
शोभा शोभा
शोभा बात कर रही,
वो कनेक्ट कराती रहती सबको. उसको हम इंट्रोड्यूस कराना चाह रहे थे.
हाँ,
विद्या
बता दें, हमें उन्हीं के साथ करना है ना.
हाँ, इसीलिए तो. कोई फागुन को भी कॉल कर लो भैया. डॉक्टर फागुन.
मैं कर देती हूँ दीदी.
प्रीति मैम आपको मैंने भेजा है.
अच्छा ठीक है.
प्रीति मैम आपको यूट्यूब लिंक भेजा है.
ओके ओके.
प्रीति मैम आपको यूट्यूब लिंक भेजा है.
ओके, हमने देख लिया.
अनुपम
2 लिंक से ज्वाइन किया.
अनुपम 2 लिंक से. अच्छा, नेटवर्क के चक्कर में.
फिरोज अभी रिकॉर्डिंग रोक दो.
ठीक है.
लेट द सेशन स्टार्ट.
ठीक है, रोक दिया.
A very warm welcome to one and all for this third session of the FOGSI Vistrit program of Karnataka. This is a joint venture both from the Safe Motherhood Committees of FOGSI and Karnataka, and it is focused on training in HDP, anemia, and GDM for the healthcare workers. Today's session is on training on anemia, management of oral and management of anemia by oral and IV, and also on diet and counseling. With the robust and prompt support of our FOGSI leaders, Dr. Rishikesh Pai, who is the president of FOGSI, Dr. Madhuri Patel, who is the General Secretary of FOGSI, Dr. Alka Pandey, who is the Vice President of FOGSI, Dr. Hema Divakar, who is the Dean of KSOGA, and not to forget our Chief Patron, Dr. Hireman. With all their support, we are able to scale this FOGSI Vistrit program in our state. At the outset, I call upon Dr. Vidya Tobi. She is our dynamic president of KSOGA, and because of her, we are having this program today. She is also the former HOD and professor at Al-Amin Medical College, Bijapur. I request you, madam, to say the words of welcome to this August gathering.
Yes, thank you, Dr. Jyoti. And as we are again going further for Anemia Mukt Bharat, and we are training our healthcare workers further. And today we are going to discuss much more about the management of iron deficiency anemia and various like diet, counseling, what are the various oral iron preparation what we can use. So today's session is very, very helpful. And let us see that how much our healthcare workers learn from that. I'm really proud to be associated with this program, and I congratulate again our dear Dr. Preeti Kumar, our Safe Motherhood Committee FOGSI, as well as Dr. Shobha Shavi and Nivedita and all the team of Safe Motherhood Committee of FOGSI and KSOGA, who are doing real wonderful work. So over to again Dr. Jyoti for further proceedings. Thank you very much for connecting with me. Thank you.
Thank you, madam, for your words. I also welcome Dr. Rajeshri Paladi, who is the Secretary General of KSOGA. I will be requesting her to sum up the events and give her expert advice at the end of the session. For a program to be successful, we need the blessings of our seniors, mentors, and well-wishers. We have Dr. Fagun, who is the National Advisor of SMC Committee of FOGSI, a staunch pillar of SMC, who has always provided unwavering and unconditional support to all the endurers of SMC at all time. We request you, sir, to shower your blessings for this program by saying through your motivational words.
Thank you, Doctor, for those kind words. At the outset, I would congratulate all the members and societies who have been associating with Safe Motherhood Committee's activities, which has aimed towards bringing the maternal mortality and morbidity down in our country. It has been excellent journey last 3 years under the able leadership of Dr. Preeti Kumar, who is the chairperson of the Safe Motherhood Committee. FOGSI has supported us a lot, and recently Dr. Pai and Dr. Madhuri Patel are a witness to the activities that are being going on. I would like to thank Dr. Hiremat for the efforts that he has put in as far as KSOGA's activity on the map front of SMC is concerned. Not to forget Dr. Hema Divakar, Dr. Nivedita and Dr. Preeti Kumar for doing and guiding all of us as far as the activities of Safe Motherhood Committee are concerned. I also welcome on board Madam Vidya Thobi and Dr. Rajeshri along with Dr. Kasturi, who are the post holders as far as KSOGA is concerned. In the past, we have had quite a few sessions on safe motherhood as well as postpartum hemorrhage, but I am delighted to know that this time, along with GDM, anemia and hypertensive disorders of pregnancy are also being taken into account. I am very glad to understand and note that more than 30 facilities have been a part of this training program, where what I have learned is more than 90 doctors and 400 plus healthcare workers are going to be trained. I sincerely acknowledge and appreciate the efforts put in by the team KSOGA along with all these stalwarts and leaders, which would help us reducing maternal morbidity and mortality by the way of capacity building and training the healthcare providers at the grassroots level, which does not include only doctors, but the first point of contact, which is very, very important. You take any of the aspects of safe motherhood, and they are the healthcare workers. It is the motto of Safe Motherhood Committee to ensure safety of every mother by way of these training programs. A lot of agencies and national and international have associated with us in the past. They would collaborate with us even in all our future activities. As far as this training and teaching program goes on, I wish you all the and all the success as far as this event is being conducted. And I am very sure that this is going to be a never-ending process. It is going to continue in future also. Wish you best of luck. May God bless us all. Thank you.
Thank you, sir, for your blessings. I welcome Dr. Kasturi Donimat. Kasturi Donimat, madam, is linked to this program as she is a past president of KSOGA, and she is also she heads the department of KIMS at Hubli. We seek your blessing, madams, through your motivational words, and through your blessings, we look forward to scaling this program much higher in our state.
Madam is joining. She was in a meeting. She's joining. 1 or 2 minutes.
Let Dr. Rashi say a few words before that.
Yeah. Good afternoon, everybody. This program of interesting session of training the staff and the nursing staff and the junior doctors is really getting exciting day by day, because we are going in a very programmed manner to reach out to these people as to right from the basic to the start, and we are then escalating as to how we can help the patients in all these manners. And it's truly wonderful to see that all of us are so dedicatedly connected on this program. At 3:30 we then come in, and then we see that all the facilities are able to join in and spread and motivate these people to log in. Yesterday, I just had a meeting with all my nursing staff who were unable to join at different times of duty hours, but then having spoken to them and made them understand the significance of why they should be joining this program and how they will get the certificate, how their attendance is important, then it reinforced up to them that yes, we have to do something. And now they understand that they really are benefited from this program. And 1 or 2 nursing staff, they came and said that, madam, we were doing, but we really never understood that there was so much of information about anemia and so many aspects of anemia, different types of anemia. And truly we are helping the healthcare providers to understand and to do better and to learn better and to be better equipped and get, because we teach one nursing staff, they'll be taking care of 10 people in the ward and on rotation, different people. So definitely for the patient care, it is really a wonderful thing which is happening here. Thank you so much for giving me this opportunity.
Madam Kasturi Madam has joined.
Thank you, madam. Welcome, Kasturi madam. We seek your blessings for the success and good outcome of this program. And I request you to say a few words and bless us.
Yeah. Thank you, Dr. Jyoti. First of all, I heartily congratulate Dr. Vidya, Dr. Rajeshri, and Dr. Shobhati, and the whole team of the same. And what you are doing is really, really important. And also Dr. Preeti Kumar from FOGSI, excellent job. She's doing it all over India. You know, so the impact of what work you are doing is making a huge difference. It's going to make a huge difference in the healthcare of all the pregnant women. And it's going to make a huge difference to the mothers and babies. It's going, I'm, because in our college, being government medical college, we see highly so many cases of severe anemia. I tell severe anemia is a totally preventable condition, and we see still 3 grams, 4 grams, 5 grams HB, which is unimaginable. I tell what they are eating. So this sensitization program, this program is very important, by which you are training the healthcare providers, and they are the ones who are really going to matter in the society at the end. You know, if you sensitize them, because patients usually don't talk much to the doctor, but they have a one-to-one very close relationship with the healthcare providers, and when they tell, it makes a huge impact, and they can address many people. As a doctor, I can tell very few people, but addressing the whole, lots and whole population, it's a healthcare providers. So the way you all are sensitizing it, making them aware, making them understand, making them, setting them what is the importance of preventing anemia, what anemia has impact on the mother and the baby. And so it's a huge difference. And there will be even the healthcare providers, when they are treating the patient, they know why they are doing that. Because most of the time, what happens, we tell them, you put this, you put that, they'll put. But they should know the reasoning behind that, and how it will improve upon the health of the mother, baby, and all. It's not just the health of the having a live baby. We can have a baby with a good intelligence, good weight, good health with this. So this program is really, really important. And I really appreciate the efforts you all are putting for this program. And I'm sure with all your this program going on all over Karnataka, we hope to see less anemia cases, less maternal morbidity, but mortality, even the infant morbidity and mortality, because anemia, as all of you know, not just on the mother's health, it definitely has an impact on the baby's growth, IQ, and so many other things. And also this nutrition anemia has an impact on the preeclampsia. And if we can, I keep telling, if we can prevent one anemia and other preeclampsia, our maternal deaths can come to almost less than, very, very less. So this, I very happy with the work which you are doing, and I wish you all the best for this program. We want to see the whole of Karnataka's healthcare workers being trained with this. Thank you for so many people joining. Thank you once again, Dr. Rajeshri, Dr. Vidya, Dr. Shobha, Dr. Preeti Kumar, and the whole team, and Dr. Jyoti. Yeah.
Thank you, Kasturi madam. Dr. Preeti Kumar, chairperson of Safe Motherhood Committee of FOGSI, is indeed a backbone for this program to happen. And I welcome you also, madam. And I hand over this program to Dr. Anupam Singh to navigate this program further. And I'll join in the end.
Thank you so much, ma'am. Namaskara and Suswagata to all the esteemed dignitaries and all those who have joined today on this virtual platform. Amongst all the duties that we discharge as members of Safe Motherhood Committee, this is by far the toughest one, to introduce our own leader. She is not just a name, she is a crusade. And she has actually taken care, she is truly a leader who knows the way, shows the way, and goes the way, and has always ensured that each of her members shine as bright as a diamond as she herself is. This is the least I could say about her. And may I now request her to give an overview of this session. Over to you,
Thank you
madam.
so much. Thank you, Anupam, for that kind and loving words. I think you always shower so much of love. And I'm really honored to be with among all the Safe Mother Committee members. And I'm really feel proud because the kind of team I have, many of the times people say that you are doing good work, but your team is wonderful. So it's all about the team. And the same is true for KSOGA team. So much of dedication Shobha is showing, and Dr. Rajshri is there as a Secretary General, very silent worker, but very hardworking, and of course, Dr. Vidya Thobi. So just few information I want to share here, since I'm there in many of the groups. A small, just an input on this, that we are finishing the trainings on anemia because it's a combined program. So some sessions would be in Kannada and some sessions would be in English. So after the 7th is over, the 7th we finish the anemia program, we will have one-on-one mentoring sessions of each and every facility. So every facility, some mentor will be deputed from KSOGA to all one facility, and they will mentor all the healthcare workers. So if they are not able to ask any question here today, or maybe on 7th or in previous sessions, don't worry about it, because you will get plenty of opportunity to get your answers from the mentors and trainers. So from 7th next week onwards, first thing, we will be sharing the recordings of all the sessions. So hear those recordings, listen to those recordings. Who could not join, please listen to those recordings. We are sharing the PPTs of each and every session. Please go through the PPTs. If you have any problem, please ask your doctor, the facility in charge. They will also help you, because each one of us have to take the responsibility. All the OBGYNs of KSOGA have to take the responsibility, the centers which are enrolled, because otherwise it will be very difficult to reach out to the mission, what we actually want, what Dr. Kasturi Madam has just now mentioned. So I'm really thankful to Dr. Kasturi Madam for appreciating and acknowledging the work. Yes, we are trying to reach out to each and every healthcare workers, not only in our country, but also in some of the neighboring countries like Nepal and Sri Lanka, we have worked. And believe me, it has brought a tremendous change. I can share with you all the data of FOGSI Vistrit at Jharkhand, and it has brought a huge change in the practices. And Anupam Center herself was a part of this program. So I would again like to thank Dr. Rishikesh Pai, Dr. Madhuri Patel, my Vice President, Dr. Alka Pandeyji, and of course, the leaders of KSOGA, very dynamic, I must say, the team, Dr. M.G. Hiramatsar, Dr. Kasturi Madam, we had been interacting in the past for the project, but somehow this was possible. Last time we were trying to do PPH, but something, worked out because I'm finishing my tenure next 6 months. But I must appreciate the efforts of Shobha, a very young girl, though she's not very much into, but still she's trying her best possible effort she's putting. And we sometimes interact even at almost very late nights also to discuss how we can make it better. So every step is important. Every contribution is important. Please come forward. And because we are also learning through these training programs, there are certain challenges, we try to overcome those. So thank you so much, and hope you learned today about the oral iron therapy. Dr. Nivedita Datta is one of the best, I must say, in a Safe Motherhood Committee, FOGSI, and she's a wonderful teacher as far as the healthcare workers are concerned. And the next speaker is Dr. Meeta. She's the professor and head of AIMS Jammu. So both the speakers are very good, excellent in the topic, in the subject. And I hope these 2 sessions would really help the healthcare workers. And at the end, I would really like to thank Dr. Fagun Shah, who is the advisor for Safe Motherhood Committee. And I think he's the backbone of whatever activities we are doing throughout the tenure. So he's a silent worker again, and he has contributed immensely in the working of Safe Motherhood Committee. So thank you once again, Dr. Fagun and Dr. Kasturi Madam. You graced the occasion, and we are truly obliged and thankful to you. Thank you so much.
Thank you once again, Madam. You are doing really great work, Dr. Preeti. And please share with us this thing of Jharkhand with me,
Madam, I'll share with you the focus group discussion that USAID conducted with the healthcare worker facility, because we were not part of it. They independently conducted about the training programs. I will share that report, and I will share the entire analysis of Vistrit Jharkhand, and you can just go through it. We have submitted this paper in Jogi. Probably it will be published soon in the Journal of Obs and Gynae Society of India.
So I'll go through that and I'll be in touch with you so that we can make a change in the
Yes,
system.
madam. Yes, madam.
Okay.
Yes, madam. Sure, sure. Thank you.
Thank you so much, Preeti ma'am. And now, without further ado, let's move on to our today's session. There are two talks scheduled for today. The first talk will be delivered by Dr. Nivedita Datta, which would be on management of iron deficiency anemia by oral iron. Dr. Nivedita, she is a consultant obstetrician and gynecologist from Bokaro, Jharkhand. She is the president of Bokaro Obs Gynae Society and also the East Zone Coordinator for Safe Motherhood Committee, FOGSI. Over to you, ma'am. Nivedita, ma'am.
Very good afternoon and namaskar.
Nivedita, can you make your
Yes.
slide full screen?
Yeah, I am. Namaskar, good afternoon to all those assembled here today.
Yes.
Today, we are going to talk about management of iron deficiency anemia in pregnancy, and my focus is going to be on the oral medications. So what is the whole objective of this training session? The major objective of this training session is that all those who are here today, who are listening to the talk today, and all those who aren't even able to hear the talk today, but probably will be mentored later, or will go on to the YouTube or the recordings to see, they should know about how to manage iron deficiency anemia according to severity and gestational age by oral iron medications. And later, Dr. Meeta Gupta will take on the injectable iron or the parenteral iron therapy. Second, the most important part, which I feel, is that should be a provider shift. And what do I mean by that? Right now, most of the counseling is done by the doctors. Doctors have little time in their OPDs. When we are seeing 40, 50 patients in our OPDs, we don't have time to counsel every woman about when to take iron, how to take iron, how much, what is the kind of diet which needs to be done. Hence, this is a very important role of the healthcare workers. You can see in the picture, these are the healthcare workers who have been taught in Vistrit, Jharkhand. And you can understand, they are hardly, they are not even qualified GNMs or ANMs, but yet they were taught, they learned, and today they are the ones who are doing the counseling in most of the nursing homes, in fact, all the nursing homes that have been trained under Vistrit project. And I hope to see the same in KSOGA, because most of you already are qualified GNMs and ANMs. So you will do a much better job than what our Jharkhand staff have done. Now, focusing on the main topic, we have so far, what have we learned so far? We have so far known what is anemia, and we know that anemia is decreased oxygen carrying capacity. So if there is less oxygen, that means less oxygen going to the baby. So hence we iron the uterus. So they will be, as well as the mother, so there will be maternal as well as fetal complications of anemia. So hence we have to manage it. We have to prevent this anemia to see that these complications do not occur. We learned about diagnosis of anemia in the last class, and we also learned that there is a thing called hemoglobinopathies, that like thalassemia and sickle cell anemia. Now, those are the hemoglobinopathies are the ones which are not corrected by oral iron. So what we are focusing on is which is the commonest cause of an anemia, and that is the iron deficiency anemia. Iron deficiency anemia can be corrected by one is food-based strategies, and this will be covered by Dr. Shobha on 7th. Then we have iron supplementations, means we are giving iron over, we are supplementing or giving whatever we are getting in diet, we are giving more than that in that. And that is the focus of my topic today. The other is definitely the improved health services like sanitations, delayed cord clamping, etc., which is beyond the purview of today's talk. So management of iron deficiency anemia is basically on 3 major parameters. One is oral iron therapy. 2 is parenteral. Parenteral means, enteral means through the intestines. That means through the mouth you're taking in and then it is going to your intestine. So that is enteral. Parenteral means which is not going through the mouth. So it has to be something which has to be injectable. It can be IM or IV, but parenteral iron is generally IV. And of course, the last one is where it is blood transfusion, because that also will improve your hemoglobin. But now again, my talk is only on 1/3 of this topic, and that is oral iron therapy. So what the reason I'm breaking it up is that you can see that oral iron therapy is, although it is the mainstay of your iron deficiency anemia, but it is not the only thing. It comprises only 1/9 of the treatment of anemia. So one should be aware of the other therapies and the other managements also. I would also request, as I go along in my presentation, I would request all those who are here to please be interactive, because I have a lot of questions in my presentations and would love it if you all could interact and put up your answers in the Q&A session. Although we have a quiz later, but it'll be nice if you could interact even during the talks. So the first question which I'm asking is, if a woman, her hemoglobin is greater than or equal to 11 gram percentage in pregnancy, that means she is not anemic, will you still recommend intake of iron tablets? Yes or no? And the correct answer is yes. And this is what is called iron prophylaxis. That means we are not giving iron for correction, but for prevention of anemia, because we know that as pregnancy progresses, the baby will require iron, the fetus will demand more and more iron, the mother can get anemic. So what you are trying to do is that you are giving her iron, even though she is not anemic, to ensure that she remains non-anemic throughout pregnancy. So the first take-home message is that even if it is more than 11, you have to give iron, and that is iron prophylaxis. So this I've already mentioned, that iron prophylaxis in pregnancy, if it is more than 11, and in a non-pregnant, it is more than 12. So what is the government recommendation? The government of India recommends that 60 milligrams of elemental iron. So if you see the tablet, any tablet of iron, it can give any dose, and below that is written elemental iron so and so. So the elemental iron requirement should be 60 milligrams and 500 micrograms of folic acid. This is weekly. This is for non-pregnant women. This is for non-pregnant women. That means which have given in age group 15 to 45, you are giving, they should give it weekly, and which is done in schools and colleges. And giving albendazole tablet biannual means 6 monthly for deworming, to prevent helminthic control, because we all know that hookworm anemia, hookworm infestation is a very common cause of anemia. So this is for women who are not pregnant. Please do not get confused. For pregnancy, what is the recommendation? And this is when a woman has a hemoglobin of 11 or more. Means unka hemoglobin 11 ya usse zyada hai. Then what are we giving? We are giving 1 tablet of iron and folic acid. Again, be careful about the dose. 60 milligrams of elemental iron. And this has to be given for 180 days during pregnancy. That means 6 months during pregnancy, it has to be given. Along with that, we have to give 1 tablet of albendazole. Deworming, ladies and gentlemen, whoever have joined, students and seniors, is compulsory in pregnancy. You have to give 1 tablet of albendazole, and that is a 400 milligram tablet. Only single dose is required, and that too after 14 weeks of gestation. It is not given in the first trimester. So this is during pregnancy and after delivery. That means postpartum, bacha hone ke baad. Again, you will give iron and folic acid tablet, again 1 tablet, and this is also for 6 months. So at the time of discharge, be very particular that you are giving iron and calcium, iron for 6 months, not just for 15 days or 1 month. Now we come to, if a woman is anemic, that means her hemoglobin is less than 11 gram percent. Now what is the dose? This is the therapeutic. Therapy means correction, treatment. So the treatment, if she is anemic, the therapeutic dose is 1 tablet of iron and folic acid tablet twice daily for 180 days in pregnancy. That means for 6 months, we are giving her iron and folic acid tablet twice a day. And this has to be continued till she delivers. If in between we check the hemoglobin and we find that the hemoglobin has become 11 or 12 gram, then we can continue it as once daily dose. Now she becomes in the prophylactic daily iron dose. So until her hemoglobin has come up to 11, she requires 2 tablets of iron and folic acid tablets in a day. When the hemoglobin becomes 11 or more, you can decrease it to 1 tablet of iron folic acid per day. But it has to be continued throughout the pregnancy and again in the postpartum period. Now, during iron therapy, it's very easy for us to say take iron tablets twice a day. Remember, the woman is eating also 4 or 5 times a day. So when should she take her oral iron? Because most people say, okay, you take it at bedtime because of the problems. So what are the problems? The problems are generally we have gastrointestinal side effects. They will say that iron, after we consume oral iron, we have gastritis, nausea, vomiting, sometimes either constipation and sometimes diarrhea also. And that is when they stop the oral iron. They'll say कि हम लोग नहीं खा रहे हैं iron because we have these side effects. Explain to her that these side effects are not serious. They can be overcome with some medicines. And even if she has side effects, the doses should be taken regularly and the whole treatment of 180 days or 6 months should be completed. Another problem which they have are black stools. So black stool is actually not a side effect. It is and it's showing that yes, she is taking iron, so the stools will be black or clay color. Now, when should we take the oral iron? What time? What is the relationship with food? Should we take it at bedtime? Should we take it in the morning? Whichever time you take it, it has to be either 2 hours before a meal or after a meal. It cannot be taken with meals. You cannot have your khana and then take an iron tablet. Even if she takes it at night, it should be taken 2 hours after her dinner. That is very important. To prevent constipation, advise her to drink lots of water and add roughage in the diet. Things like she can take chapati, dalia, and all the things which have increased roughage, saag, all these things can cause increased roughage. So she can add all these things in her diet. Iron folic acid treatment should always be supplemented with diet which is rich in iron. And this topic will be covered by Dr. Shobha tomorrow. So please listen to Dr. Shobha's topic tomorrow and remember the diet which is rich in iron. Then another vitamin which is very important for absorption of iron is vitamin C. Vitamin C, common sources of vitamin C are nimbu, amla, all the citrus foods. So if you take the iron tablet with vitamin C, the iron gets better absorbed. And if the iron is better absorbed, there is more iron which is going to the circulation, and obviously the hemoglobin will rise better. Then any diet which is rich in proteins, minerals, and such nutrients. So what are the, enhancers? The word enhancers means something which increases it. So what increases iron absorption? Like you have taken one tablet, you obviously want that tablet to get absorbed from the stomach into the blood. Because once it goes into the blood, only then it can go into the circulation to the liver and all to produce, and bone marrow to produce iron. So what will be the things which will increase the iron absorption are, one is heme iron. And heme iron is present in all the non-veg diets. So meat, poultry, fish, seafoods. So all these things which any of these non-vegetarian diets increase iron absorption. Another thing which I've already mentioned is vitamin C. So you can take vitamin C either as food or even a tablet of vitamin C you can take if you want. It can increase the absorption. Now, this is important. What are the things which inhibit iron absorption? So what are the things which you are taking जिसमें iron absorption कम हो जा रहा है? Tea, coffee के साथ नहीं लेना. So you can see that glass of milk and she's saying no. She's not saying no to milk per se. She's saying no to milk and tea with the iron tablets. So do not take tea, coffee, milk with iron tablets. The iron tablet should not be taken with phytates. Phytates are there in cereals, rice, chapati. So anything which contains cereals, even idli, dosa, because that contains rice, legumes, pulses, dals. So anything which has phytates, you cannot take iron. So therefore, you cannot take iron tablets with your meals. खाने के साथ iron tablet नहीं लेना है. खाने के 2 घंटा पहले लेना है या खाने के 2 घंटा बाद लेना है. You cannot take iron and calcium tablets together. Iron and calcium एक संग लोगे, they will not both, none of them are going to get absorbed well. So iron tablet has to be spaced out with calcium tablets. So do not say one tablet iron, one tablet calcium, take it, and the woman takes it together. Again, there is no improvement in the hemoglobin. So they should be taken separately. I hope this aspect is very clear, because you are the ones who are going to counsel her about when to take iron, how, if the medicine is advised when. So you have to ask her when she is taking her meals, and that is when you have to space out her iron. So this part you have to understand very well. Next is, we are coming to the major topic about how will you treat anemia, and we are going to do it trimester wise and severity wise. So the question to you is, what do you do in the first trimester if there is anemia? Do you give diet? Do you give oral iron? Do you give injectable iron? Or do you give blood transfusion? Please answer in the Q&A. So in first trimester, that means now we are talking of first 1 week to 12 weeks. In that time, mild to moderate anemia should be corrected by diet. However, if the anemia, if you find that it is the moderate is on the lower side, you can give oral iron. So in moderate anemia, you can give oral iron, although the gastritis.
Just hold on, Nivedita. Please mute yourself. Firoz, see whose video speaker is on. Please mute them.
Okay, ma'am.
Thank you. Thank you. Thank you. Thank you. Yeah, thank you. So in the first trimester, you have nausea, vomiting as such in pregnancy. And as I said, oral iron also causes nausea, vomiting. So therefore, a lot of doctors say that do not take oral iron in the first trimester. However, it's not contraindicated. मतलब ऐसा नहीं कि आप नहीं ले सकते हैं. आप ले सकते हैं. Nausea, vomiting का problem जरूर होता है. So preferably in the first trimester, diet से control कीजिए anemia को. But if it is severe anemia, then you require blood transfusion. Now the question was, do you deworm routinely in pregnancy? And the answer should be yes. And I've already mentioned that in pregnancy, what is the dose of deworming? The dose is 400 milligrams after 14 weeks, and a single dose has to be given. Now this is the chart. You can take a screenshot of it, but I'm going to explain to you slowly. So in anemia, if it is less than 11 grams, I'm going to go piece by piece also, but please try to focus on this chart. Let's go from below upwards. If it is severe anemia, that means hemoglobin is less than 7 gram %. If it is less than 7 gram %, again, we divide it into very severe, where the hemoglobin is less than 5, that means 4 and below. Here she requires blood transfusion. So less than 5 gram, that means 4 and below, very severe anemia in any trimester. Remember, less than 4 and below, in any trimester, she requires blood transfusion. Between 5 to 6.9, what is to be given? You have to, if it is less than 34 weeks, you will require parenteral iron. So you will have to refer to a place where parenteral iron therapy can be given if you are doing in a first referral unit of the center, which does not have a backup of parenteral therapy. Now, if it is more than 34 weeks, then again you will require, because there is no time, more than 34 weeks, she doesn't have any time for even anything to act. You cannot improve her hemoglobin by even parenteral iron therapy. So more than 34 weeks, she will require blood transfusion. So very severe anemia, blood transfusion. Severe anemia, more than 34 weeks, blood transfusion. Less than 34 weeks, she will require parenteral iron therapy. Now let us come to moderate anemia. That means we are coming to between 7 to 9.9, or mild anemia, that means 10 to 9.9. So it's 10.9. So basically mild and moderate anemia, again, we are going to take it into less than 34 weeks and more than 34 weeks. So if it is less than 34 weeks, what do? We start off with oral iron. Now oral iron, as I've said, 1 tablet twice a day. That means DD is the dose. And you will reassess after 1 month. Sorry, do not just immediately test 1 week or 15 days. Wait for 1 month. It requires time for the hemoglobin to increase. After 1 month, if you see that, yes, the hemoglobin has gone up by 1 gram per deciliter. If her hemoglobin was 8.5, after 1 month, it should be 9.5. Do not expect 8.5, say 12. No. 1 gram per month. Hemoglobin has to go up. If it is going up that much, then yes, she is responding to oral iron and she can continue with oral iron. Now, if the hemoglobin is not increasing, means say she was 9 gram and after 1 month she has continued to remain 9 gram, then you have to investigate. There has to be some other cause. If she's taking the iron tablets properly, there has to be some other cause why her hemoglobin is not going up. She could have hemoglobinopathies, as was discussed by Dr. Ekta. So you have to investigate. Or if her serum ferritin is low, we have already spoken about it, and that means she has iron deficiency anemia, then she might need injectable or parenteral iron therapy. So let us be clear about it. In less than 34 weeks, she will require 2 tablets per day, reassess after 1 month, and the hemoglobin should go up by 1 gram per cent. That means 1 gram deciliters. That is the management. Now, if suppose she cannot tolerate oral iron, she says, no, the oral iron, I just cannot tolerate oral iron. I keep having diarrhea or I keep having vomiting and I cannot take oral iron. That means then she will require injectable iron. If iron deficiency anemia is confirmed, then you have to go in for injectable iron. If her pregnancy is more than 34 weeks, we discussed the first column was less than 34 weeks. Now, if she is more than 34 weeks and she has mild to moderate anemia, then she will require injectable iron. Because as I said, oral iron will take at least 1 month to improve. Less than 34 weeks, more than 34 weeks, which is 35, 36 weeks, we have less time on hand. So then we have to go in for straight injectable. So what is the role of oral iron? It's in less than 34 weeks. That means from 13 weeks to 34 weeks. Anemic, 2 tablets per day. Non-anemic, 1 tablet per day will continue till term. So now let us see, let's quickly recapitulate this. Hemoglobin less than 5 gram per cent in any trimester, we go in for blood transfusion. Between 7.1 to 10 gram per cent, less than 34 weeks, we are giving therapeutic oral iron. That means 1 tablet twice daily along with vitamin C and B complex. Now, more than 34 weeks, hemoglobin less than 5, what are we giving? We are giving blood parenteral iron. Greater than 5, parenteral iron. If the hemoglobin is 7 to 10.9, the woman is non-compliant. As I've said, she cannot take oral iron. Then we have to give in for parenteral iron. And if the hemoglobin is more than 11 gram, this is all less than 34 weeks. We are still below 34 weeks. If 34 weeks, if she is not severely, and she is severely anemic, but not very severe, we can think of parenteral iron. Moderate anemia, mild to moderate anemia, non-compliant to oral iron, parenteral iron. Not anemic at all, hemoglobin is more than 11 gram per cent, then prophylactic iron, that is 1 tablet per day. I hope I'm very clear about this because this is something which you have to explain very well. Now here we are going to gestational age more than 34 weeks. Again, in this here, if you can see here, I've come to just less than 7. Means severe anemia, blood transfusion. Mild to moderate to severe, mild to moderate anemia, parenteral iron, or if parenteral iron is not indicated, like hemoglobinopathies, then you can have blood transfusion. And if it is more than 11, then again you will continue with the oral iron. Please continue with the oral iron if she is normal, 11 gram per cent, and you can continue it till term. Now, how will you understand that the woman is responding? I've already mentioned it. I'm restating what I've already mentioned. Estimate hemoglobin after 1 month, and reassessment has to, and how much is the dose which has to go up? It has to go up by 1 gram per cent. Woman will also feel better. Her symptoms of anemia, which have already been mentioned, will decrease. The hemoglobin rise should be 1 gram per cent per month. And then another thing, if you do the CBC, you will see the reticulocyte count is also increasing. If there is no response after 4 weeks, please reinvestigate and advise therapy according to the pathology. So antenatal care of anemia has been covered by oral iron therapy. Now we come to postnatal, means she's delivered. She's delivered 1 day back, 2 days back, and now you're discharging her. Before discharge, should you do a hemoglobin testing before discharge? Yes, because if you find that she is anemic postnatally, it is very important because they have complications again. Like the mother can have PPH, she can be increased chances of infections, UTI or sepsis, cardiac problems. The breast milk will be poor in quality. And if the breast milk is poor, what happens to the baby? The baby gets less milk, poor quality milk. So the baby's physical and neural development is going to be poor. तो माँ और बच्चे दोनों के बेनिफिट के लिए postnatal anemia has to be corrected. So all women have to be tested, all postpartum hemoglobin testing routinely, and every woman who has delivered should be tested within 24 hours to 48 hours. And what should be the cutoff? There are 2 guidelines for this. American College says something different. WHO says something different. We are sticking to the WHO guideline, which is 10 gram% से ऊपर होना चाहिए. So if 10 gram or ऊपर, अगर 10.5 है postnatal, then it is not anemic. But if it is 9.5 also, she is anemic. And again, the treatment is, if she is not anemic, that means hemoglobin is 10.5 or 11, then you give 1 tablet of iron, again a 60 milligram elemental iron. Please check. आप लोग हर एक strip पे देखिएगा elemental iron कितना है. Some iron preparations have very little elemental iron. So you have to check to see elemental iron. Even the tonics which are given, very little elemental iron. Some tonics will have only 15 milligram elemental iron in 5 ml. So you have to see how much is the elemental iron. 60 milligrams of elemental iron and 0.5 milligrams of folic acid, 1 tablet a day if it for 6 months after delivery. Again, for 180 days. So agar hemoglobin is, she is not anemic, then 1 tablet. And if she is anemic, agar uska mild 9 से 10 gram hemoglobin hai, then you give oral iron twice daily for 6 months. That means 180 days. Now for moderate anemia, that means her hemoglobin is 7 to 8.9. Please give her injectable iron before discharge. That takes care of it. Whether how much iron she'll take, whether she can get absorbed, because now she will not do regular checkups with you. So discharge her after giving her injectable iron. For severe anemia, that is less than 7, give her blood transfusion before discharging her. So postpartum anemia also has to be taken care of. ऐसा नहीं है only antenatal period में anemia को देखा and फिर then नहीं किया. Now, if the woman has not been dewormed, some doctors do, I get patients from some peripheral areas and I find that they have not been dewormed in the antenatal period. So if they have not been dewormed in the antenatal period, please give her deworming in the postnatal period. You will anywhere call her at 6 weeks. You will call her at follow-up at 6 weeks because that is when you give contraception advice. So when you call her at 6 weeks, or please check whether the hemoglobin is rising. There is adequate response to hemoglobin. And if she is not rising, then again, and you've confirmed iron deficiency anemia, not rising, then she might think, again, you might think of injectable iron. So now why it is very important to intervene to correct antepartum and postpartum anemia. Dear friends, आप लोग जो भी nurses logged in है, जो भी सुन रहे हैं, lab technicians, OT technicians, nurses, याद रखिए, remember that anemia को correct करेंगे तो we can definitely reduce माँ का not only deaths but morbidity, मतलब prolonged जो इनकी problems होती हैं, infections कम होते हैं, mother के aches and pains कम होते हैं. So anemia is dangerous because it contributes 20% of maternal deaths. Indirectly, maybe directly they are not dying of anemia, but the indirect causes anemia is much more. So maternal iron and folic acid supplementations can go a long way in improving lives. There are a lot of interventions, जो मैंने बोला था कि healthcare interventions हैं. There are a lot of interventions, but right now what we are mainly focusing on is iron therapy for iron deficiency anemia. Thank you very much.
Thank you so much, ma'am, for this wonderful talk. The ease and effortlessness with which you have explained this complicated topic of anemia management by oral iron was really commendable. I think the healthcare workers must have understood pretty well. So now moving on to the next talk. Our next erudite speaker is again a member of Safe Motherhood Committee. She's Dr. Meeta Gupta, Professor and Head Department of OBGYN, AIMS Jammu. She would be covering the management of iron deficiency anemia by IV iron. Over to you, ma'am.
Thank you, Anupam. Thank you so much. I hope I'm audible.
Yes, you are.
Okay, I'll just share the screen. Okay, thank you so much, ma'am. Thank you, Preeti ji, as chairperson, under whose guidance we have been working tirelessly. We hope to, just fulfill 1% of our energy. So we think we'll be able to do our work justifiably. Thank you to the entire Karnataka team, Vidya Thobi ma'am, Rajshri ma'am, and Shobha ma'am for giving us this opportunity under Hema ma'ams to be present among you. So after Nivedita Di's talk of how to go forward with oral therapy in iron deficiency anemia, I will be talking about parenteral therapy. And as Dr. Nivedita has said, that parenteral therapy is something that is not taken by mouth. So it has to be an injectable therapy, which could be intramuscular or intravenous. So I would be talking in the next 15-20 minutes about iron therapy not taken by mouth for iron deficiency anemia. So to start, the parenteral iron therapy is what is the injectable therapy for iron deficiency anemia. It is very commonly available in market now, and you have to be just aware of what brand name is available in your market, in your region. So if you look at the indications for this parenteral therapy, as Dr. Nivedita has said, the Government of India guidelines are very clear that if the patient is pregnant between 20 to 34 weeks, that is round about 5th month of pregnancy to 8th month of pregnancy, and she has moderate anemia, that is from 7 grams to less than 9 grams, then parenteral iron therapy has to be offered to the patient. This patient is not nearing delivery, so parenteral iron therapy is one of the best options for tackling anemia in this patient. If the patient is more than 34 weeks and she has moderate anemia, that is, she has 7 to less than 9 grams of hemoglobin, and she has some symptoms. If she's clinically, she has breathlessness, she has other problems of fetal growth restriction, then blood transfusion is the therapy. But if the patient is not clinically having any problem, then parenteral iron therapy has to be offered. So the Government of India guidelines are very specific that injectable iron therapy has to be given in moderate anemia, that is from 7 to less than 9 grams of therapy. There are some other indications for parenteral iron, like Dr. Nivedita has said, just to reinforce that if the patient has very poor compliance, that is, she is not taking oral medications, or she cannot tolerate oral medications because of gastroenteritis, loose motions, constipation, in these patients, we can offer them parenteral iron therapy. So now that we have decided to give parenteral iron therapy, we have to understand what are the prerequisites, what are the conditions that have to be fulfilled before we offer this parenteral injectable iron therapy to the patient. So what is important is 4 C's. The first C is to confirm, yes, that the patient has iron deficiency anemia. A consent has to be taken because it is an intervention injectable therapy. So a consent has to be taken. We have to check if there are any contraindications for the iron therapy to be, if present, the patient cannot be given injectable therapy. We have to check for the expiry of the ampule, whether the expiry date of the ampule is right.
is not expired, the ampule is not expired. Once these 4 C's are ascertained, then because it is an injectable therapy, we have to gather all the equipments like IV cannula, syringes, normal saline, alcohol wipes or cotton spirit, and a fixator to start for this injectable iron therapy. Please remember that before the start of the therapy, a consent has to be taken, and this has to be taken by the medical officer in charge of that nursing home. It may be any duty doctor, but it has to be a medical officer. Please remember that the medical prescription should have the name and signature of the doctor who is ordering, and also the doctor under whose supervision this transfusion has to be done. Remember, how much is the quantity, the date and time of the transfusion all has to be noted on the case sheet of the patient. The proper diagnosis of iron deficiency anemia has been made before starting of the transfusion. If patient has taken any previous transfusions, please mention that. If the patient has to take further transfusions after today or tomorrow, also mention the follow-up and the next due date for the transfusion, as well as you have to calculate what is the total dose of the parental iron that has to be given, in how many settings, and how much dose in each setting is to be given. This all has to be charted on the case report of the patient. Once everything has been documented, because it is an intervention, you're giving an injectable therapy, please follow hand hygiene, full aseptic precautions, and under proper supervision, it has to be done. Always start with a test dose, and it has to be done at a very slow rate so that close monitoring of blood pressure, pulse rate, respiratory rate, temperature, and SpO2 of the patient has to be taken as well as documented properly. Once you have everything prepared, in your pre-transfusion observation, please document the blood pressure, the pulse rate, the oxygen saturation, the respiratory rate, and the temperature of the patient in the case record sheet. An emergency tray should always be near the bed of the patient. The appropriate intravenous access, which is patent, should be documented. And always remember that there is a risk of reaction. So cardiopulmonary resuscitation facility should be available in your nursing homes. This is one of the foremost requirements before starting off parental therapy. If your facility does not have a cardiopulmonary resuscitation facility, please refer the patient to a facility where this CPR is possible, and then only start with your injectable therapy there in the facility which has a CPR facility. The emergency tray should have injection adrenaline, hydrocortisone, injection AVIL, as well as oxygen cylinder, just for in the rarest possibility of any anaphylactic shock because of these injectable therapy. After the transfusion has completed, please document the completion time, the total volume that has been transfused. Everything has to be documented in the patient health record system. Also, you have to record if any adverse effect has occurred during the transfusion time. After documenting everything, also advise the next follow-up date of the patient for further therapy or for routine antenatal checkup. So, coming to the parental iron therapy that are available in the market. This is the chronology. Yeah, it was how they appeared in the market. The first generation was iron dextran. Then came the second generation, that was ferric gluconate, or what we most commonly know as the iron sucrose injections. The latest or the newest block on this road is ferric carboxymaltose and iron isomaltoside. These two have actually, these third generation injectable iron has really changed how we manage anemia. So once you have so much of at your disposal, you have iron dextrose, you have iron sucrose, So you are left with the, how do you select the ideal parental iron? What you have to remember is that iron dextran was the first generation maximum risk of anaphylaxis. Iron sucrose is a good option, but the only problem is that a multiple doses has to be given and you need multiple visits to the nursing home. The best is ferric carboxy maltose because we can give a high dose of iron in a single dose in a single sitting, and it has very less chances of hypersensitivity reactions. Another, that is iron isomaltoside, is very new and not much evidence, clinical evidence is available. So for the time being, ferric carboxy maltose is one of the best injectable iron therapies for the patients available. Coming to the first generation, that was the iron dextran. The problem was iron dextran was that it is intramuscular. It had to be given intramuscular. It was very painful, and it is not recommended nowadays because of better options available. Then came the intravenous iron sucrose. It is very safe and it was very easily available because iron load was given. So a lot of iron was available for erythropoiesis. No black box warning. It means that in foreign countries, if any injection which has a very high reaction rate, they come with a black box warning. So this injectable iron does not have a black box warning. That means it does not carry very serious side effects. It is said that no test dose has to be given, but we always say that precaution has to be taken care of and the patient has to be watched for any reactions. The only problem with this injectable iron sucrose is that it has to be given alternate day therapy for about only 1 to 3 times in a week to a maximum of 600 milligram in 1 week. This is the only disadvantage with iron sucrose, that we have to have a multiple sittings. And remember, because intravenous iron, these are injectable therapy, proper disposable biomedical waste management has to be taken. So these are plastic. So it has to be taken into, somebody will like to answer? In which color bin? I don't know. Somebody has answered or not?
No, I can't see any answers in the Q&A.
So biomedical waste has to be taken care of. So it has to be in the red bins. So this is the latest, the wonder drug that we are talking about is this is just to continue with the iron sucrose, that normally 200 milligram of injectable iron sucrose is to be given in 100 ml of normal saline bottles. Maximum 600 milligram dose has to be given on an alternate day therapy basis, and about 2 to 4 days is the recommended time between each dose. Like if day 1 is given 200 milligram, then day 3 or day 4 can be given another 200 milligram, and then again a gap of 2 or 4 days has to be taken to give a 200 milligram. So ideally 600 milligram dose, the maximum dose, is to be covered in about 1 week's time. The infusion at the start is given at a very slow rate of about 20 to 30 drops to watch for any reactions. Once this 5 minutes have crossed and patient does not show any reaction, the rate of the drop infusion can be increased to about 80 to 90 drops per minute, and the entire infusion can be finished in about 15 to 30 minutes. Please remember that no oral iron has to be given once the patient is taking injectable iron therapy. Only injectable iron is to be given. No oral iron therapy has to be given with this injectable parental therapies. Please remember this. And vital patient monitoring of the vitals before, during, and after infusion is most important to watch for any reactions. So how do we determine how much iron has to be given? This is calculated by the Kenzoni's formula, which say that the body weight of the patient, that is taken into kg,
multiplied by what is the target hemoglobin minus the actual hemoglobin, which is taken into gram per deciliter, multiplied by 2.4 plus how much iron stores we want to give to the patient in milligram. So it looks difficult, but it is very easy. We'll just go through an example. That Veena is one patient. She is 35 years, para 3, gravida 3, 32 weeks of pregnancy, and her hemoglobin is 9. She is not able to tolerate oral iron therapy, and so the doctor has planned for injectable iron therapy. So if her body weight is 50 and target hemoglobin is 12, the actual hemoglobin is 9. So I would request the healthcare workers who have joined to please calculate what is the total dose that has to be given according to this Genzoni's formula. That is 2.4 into target hemoglobin minus actual hemoglobin into body weight plus 1000 milligram, that is the stores. Can you please somebody check if we have any answers?
No, ma'am.
So not as yet, not as yet. Huh?
Okay, so just to, it is 2.4 into 12 is the target and 9 is the actual hemoglobin of the patient into the weight, that is 50 kg plus 1000 milligram. So this is how we calculate the total dose. So this comes out to be 1360 milligram. So this is the total dose that has to be given to the patient. So now this is what we are talking about, iron carboxymaltose, the wonder drug, the injectable iron that has actually brought a revolution in the treatment of iron deficiency anemia. Why? Because a very high dose of iron can be given at one setting, and a rapid administration within half an hour, it can be finished, 15 to half an hour. A single dose of about 1000 milligram of iron can be given once diluted in 250 ml of normal saline, and this entire 250 ml of the normal saline can be infused over 15 minutes. So you can see the advantage. Such a high dose of 1000 milligram, only 15 minutes of time, and the patient does not have to come repeatedly. So this is why we are saying this has brought so much revolution in in the management of this iron deficiency anemia. Another advantage is that it does not have any major side effects because it does not cross-react with other antibodies. The serum ferritin levels, because you're giving so much of high dose of iron, so the serum ferritin levels, they normalize within 3 weeks, and very less iron toxicity is seen with this injectable iron carboxymaltose. So just to reinforce, over iron sucrose, FCM iron carboxymaltose can be given in a very high dose of 1000 milligram as compared to 200 milligram of iron sucrose in a single infusion. So very few clinical visits as well as very low rate of injection site infection reactions are there. So carboxymaltose is much better as compared to other available iron sucrose. How do we administer this? We have to be diluted in 0.9% of normal saline solution. The normal dose is about 20 milligram iron per kg body weight, but please remember the maximum can only be 1000 milligram of iron can be given in one sitting. We cannot exceed more than 1000 milligram of iron in a single sitting. If it is a 10 ml, this is equivalent to 500 milligram of equivalent iron. It has to be diluted in 100 ml and can be administered over 6 to 7 minutes. Likewise, the 20 ml will have the maximum dose of 1000 milligram of iron. This has to be diluted in 250 ml of normal saline, and this has to be given over 15 minutes. So single visit, 15 minutes of time period, and such a high dose of iron can be given. This decreases so much of patient load, visits to the hospital, the patient interactions coming, like every time she has to leave, get admitted. So everything is reduced because of iron carboxy maltose. So we have given the iron carboxy maltose or any other injectable. Now, how do we check for the response? It is said that the hemoglobin level rises about 1 gram per week, and this can be seen by the increase in the reticulocyte within 3 to 4 days. Now, it is always, we have talked about all the good things, but just to have, because it is injectable, so side effects has to be watched about, and this is usually due to allergic reaction. This could be just a mild skin rash, or the patient may have chills or rigors. Some may even have low-grade fever, or someone may manifest with the severe grade, that is the anaphylactic reaction. So just in case you're giving an injectable iron therapy and patient starts having a reaction, so what do? Immediately stop the infusion, apply oxygen mask, take the vital signs, which include blood pressure, pulse rate, temperature, and SpO2 of the patient. The emergency tray has to be always nearby when we are giving injectable iron therapy, and immediately call the doctor on duty. If you suspect a mild transfusion reaction, what do we mean by a mild transfusion reaction? Is that a slight temperature rise is there with no other symptoms like rigors, chills, chest tightness, or there is a rash, which is a small localized rash. Then this is what we say a mild transfusion reaction. Then we stop the infusion, monitor the patient for 15 minutes, document all the vital signs, and if required, injection able dexamethasone has to be given. The doctor is informed, and after 15 minutes, if the patient settles down, then injectable iron can be restarted. But please remember that once you restart and the patient again develops any reaction, then this means it is a major reaction, and immediately stop the transfusion and treat the patient as having a major reaction. So what you mean by a major reaction is once you have a high grade of temperature, and or if patient has a rash of more than 2/3 of the body, it is not localized, it is covering more than 2/3 of the body, then immediately stop, give injection able dexamethasone, as well as please follow whatever the protocols are followed in your hospital, collect the blood samples as advised by the doctor and sent for an X-ray. You have to monitor and document. Please remember, documentation is most important, that even if you are monitoring and you don't document, that means you are not doing it correctly. So monitor and document all the vital signs every 15 minutes or earlier if the patient is very sick. And always document each and every reaction, including the symptoms, the investigations, and what was done and what was the ultimate outcome in the patient record, so that once the patient comes next time, you have each and everything documented in the patient's case sheet. So we have talked about what are the prerequisites, how much do we give, and what are the any reaction if occurs. We also have to remember that there are few contraindications to the parenteral iron therapy in which the patient is not given injectable iron therapy, and they are congestive heart failure, any history of allergy to previous injectable iron therapy, asthma, eczema, hemochromatosis, liver cirrhosis, rheumatoid arthritis, and acute renal failure. Please remember, in these cases, the patient cannot be offered parenteral iron therapy. Thank you. And if there are any questions, any confusion for Dr. Nivedita's or my talk, we are there to help you.
Dr. Neeta, could you
I
just
think
tell
your
them
talk was
about
so much full of clarity, madam. That is, nobody is finding any confusion. And thank you so much. Thank you so much.
Just a minute, Dr. Jyoti. Dr. Neeta, could you please tell them about the route of the test dosing? Because you've mentioned about the test dose, but how to administer the route of test dose?
For the injectable iron therapy, IV, it has to be given of 1 ml in subcutaneous, and then you put a mark. Can be given that way also. If you have a good therapy, good monitoring, then 1 ml can be given as an injectable therapy, and the patient can be monitored for pulse rate, BP, and SpO2 and temperature. Both the methods are available. It depends upon which is what is your local doctor says it. So injectable iron therapy, usually the cannula is there. So 1 ml we give them, and then we monitor the patient for the pulse rate, respiratory rate, temperature, and SpO2, as well as any of the reactions like she's having rigors or having chest breathlessness or any discomfort. This is how we monitor for any reaction of the patient. This is how we test dose the injectable iron therapy.
So the test dose in injectable iron for the crowd is also intravenous. The IV line is already there. You have given the IV injection. So initially give a bit slowly, as Dr. Meeta has said, and that functions as monitor. That will function as the test dose. You do not have to give a separate dosing for a test dose. So this is what I wanted you to explain to the
Ma'am, there's a question in the chat box. There's a question in the question and answer box that what are the complications if transfused without knowing any history of asthma and cardiac problems?
See, your complications are going to be the same. Asthma, usually the patient will have any chest discomfort. So you do not realize whether it is because of asthma or it is because of reaction. So that is why we are saying if the patient is on your routine antenatal, she will definitely give you a history of asthma. And that time, the treatment of reaction to an injectable iron therapy and as a patient for asthma is entirely different. So you always check.
See, if your woman is asthmatic, before Dr. Meeta has already mentioned, even before starting the intravenous, you have to examine the woman. So even before that, you have checked her respiration and her chest. If she is asthmatic and in acute phase, she will definitely have bronchi. You have auscultated the chest. आपने ऐसा नहीं कि एक फटाक से IV line start किया, NS में iron डाला and run कर दिया. No, you will examine pre-infusion, during infusion and post-infusion. मतलब इंजेक्शन देने से पहले भी देखना है, during भी देखना है और उसके बाद भी देखना है. वो इसीलिए आपको शुरू से लेके एंड तक देखना है. अगर उसको हार्ट डिजीज भी है तो भी इंजेक्टेबल आयरन से कोई प्रॉब्लम्स नहीं होते हैं. ऐसा नहीं है कि इंजेक्टेबल आयरन से हार्ट डिजीज का हार्ट फेलियर में जाती है. नॉट विद आपका वो 100 ml नॉर्मल सलाइन से वो हार्ट फेलियर में नहीं जाने वाली है. बट आप जिस कुछ भी रेट में दीजिए उतना कोई भी हार्ट टॉलरेट कर लेता है. तो 100 ml नॉर्मल सलाइन विल नॉट lead to cardiac failure, even if a woman has got some kind of heart disease. But unless she is already in heart failure, then it is a different thing. But that you've already checked. If she is dyspneic, if she has bronchi, you have done a pre-infusion assessment. So ये जरूरी है that you do before infusion. That is very important.
I think Shobha, can you just translate in Kannada?
Dr. Rajeshri will give the sum up of the whole sessions in the end after this quiz, madam.
Sure, sure. I'm here. I'll take it after.
Just to reinforce, the contraindication was not cardiac disease. The contraindication was congestive heart failure. So for an injectable iron therapy, you can give it to a cardiac patient. Just the patient should not be having CHF. That is what we wanted to tell you. A cardiac patient will not have a problem, because it is a very 250 ml or 100 ml. So if your doctor is prescribing, she will take care of the cardiac status of the patient and then only advise.
I think someone must translate in Kannada before taking the quiz, because maybe it is possible that the healthcare workers would not have received the proper message.
Yeah, I'll do that. I'll do that.
Please translate 5 minutes or 7 minutes. Please translate in Kannada so that after that we take up the quiz.
Okay, ma'am.
Shobha, you would like to do that or you want me to do? Shobha? Yeah.
Ma'am, both the topics cover it, as well as the question which they have asked, answer that question in Kannada. Oral as well as injectable. If you want, I can.
ಇವಾಗ ನಮಸ್ಕಾರ ಎಲ್ಲರಿಗೂ. ಇಂದಿನ ಸೆಷನ್ ಅಲ್ಲಿ ತುಂಬಾ ಆಲೋಚಿಸಿ ಒಳ್ಳೆ ಒಂದು ಕಾಂಪ್ರಹೆನ್ಸಿವ್ ಮೆಥಡ್ ಆಫ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಅಂಡ್ ಕೇರ್ ಬಗ್ಗೆ ಇವತ್ತು ಇಂದಿನ ಸ್ಪೀಕರ್ಸ್ ವಿಸ್ತಾರವಾಗಿ ಹೇಳಿದ್ದಾರೆ. ನಿಮ್ಗೆಲ್ಲರಿಗೂ ಅರ್ಥ ಆಗ್ತಾ ಇದೆ ಅಂತ ನಾನು ಭಾವಿಸ್ತಾ ಇದ್ದೀನಿ. ಈಗ ರಿಯಾಕ್ಷನ್ಸ್ ಬಗ್ಗೆ ಒಂದು ಪ್ರಶ್ನೆ ಇತ್ತು ಚಾಟ್ ಬಾಕ್ಸ್ ನಲ್ಲಿ. ಇಂಜೆಕ್ಷನ್ ಕೊಡೋದ್ರಿಂದ ಕಾರ್ಡಿಯಾಕ್ ಫೇಲಿಯರ್ or ಅಸ್ತಮಾ ಎಕ್ಸಾಜರೇಟ್ ಆಗುತ್ತಾ ಅಂತ. ಸೊ ಮುಖ್ಯವಾಗಿ ಏನು ತಿಳ್ಕೊಬೇಕು ಅಂತಂದ್ರೆ, ಯಾವುದೇ ಟ್ರೀಟ್ಮೆಂಟ್ ಆಗ್ಲಿ ಯಾವುದೇ ಪೇಷಂಟ್ ಬಂದಾಗ ಫಸ್ಟ್ ನಾವು ಅವ್ರದ್ದು ಜನರಲ್ ಚೆಕಪ್ ಮಾಡ್ಲೇಬೇಕು. ಅಂದ್ರೆ ಅವರಿಗೆ ವಿಸ್ತಾರವಾಗಿ ಲಂಗ್ಸ್ ಆಗ್ಲಿ, ಹಾರ್ಟ್ ಆಗ್ಲಿ, ಸ್ಟಮಕ್ ಆಗ್ಲಿ, ಅಬ್ಡಮಿನ್ ಆಗ್ಲಿ ಇದೆಲ್ಲ ನಾವು ಚೆಕ್ ಮಾಡ್ಕೊಂಡು ಅವರಿಗೆ ಇನ್ಯಾವ ತರ ಅಲರ್ಜಿ ರಿಯಾಕ್ಷನ್ ಅಥವಾ ಹಿಸ್ಟ್ರಿ ಇದೆನಾ ಅಂತ ಕೇಳ್ಕೊಳ್ಳೇಬೇಕು ನಾವು ಡೆಫಿನೆಟ್ಲಿ ಬಿಫೋರ್ ಸ್ಟಾರ್ಟಿಂಗ್ ಎನಿ ಟ್ರೀಟ್ಮೆಂಟ್. ಸೊ ಅಸ್ತಮಾ ಪೇಷಂಟಿಗಾಗ್ಲಿ ಅಥವಾ ಹಾರ್ಟ್ ಫೇಲಿಯರ್ ಪೇಷಂಟಿಗಾಗ್ಲಿ ಇಂಜೆಕ್ಷನ್ ಇಂದ ಎಕ್ಸಾಜರೇಟ್ ಆಗೋದೇ ಇಲ್ಲ. ಆಗ್ಲಿ ಅವ್ರು ಆಲ್ರೆಡಿ ಹಾರ್ಟ್ ಫೇಲಿಯರ್ ಅಲ್ಲಿ ಇದ್ರೆ ಆವಾಗ ಏನಾದ್ರೂ ತೊಂದರೆ ಆಗ್ಬೋದು. ಬಟ್ ನಾವು ಕೊಡೋದು ಓನ್ಲಿ 100 ml ನಾರ್ಮಲ್ ಸಲೈನ್ ಆದ ಕಾರಣ ನಾವು ಕೊಡೋ ನಾರ್ಮಲ್ ಸಲೈನ್ ಇಂದ ಯಾವ ರೀತಿ ತೊಂದರೆ ಹೆಚ್ಚಿಗೆ ಆಗೋದಿಲ್ಲ. ಒಂದ್ ವೇಳೆ ಅವ್ರಿಗೆ ಆಲ್ರೆಡಿ ತೊಂದರೆ ಇತ್ತು ಅಂದ್ರೆ ಅದನ್ನ ನಾವು ಕಾಣ್ಕೋಬಹುದು. ಆಗ್ಲಿ ಪ್ರತಿ ಸಲ ಯಾವುದೇ ಪೇಷಂಟ್ ನಾವು ನೋಡಿದಾಗ ಅವ್ರ ಪೇಷಂಟ್ ನಲ್ಲಿ ವಿಸ್ತಾರವಾಗಿ ಎಲ್ಲಾ ರೀತಿ ಚೆಕಪ್ ಮಾಡ್ಕೊಂಡೇ ನಾವು ಅವರಿಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡ್ತೀವಿ. ಫಸ್ಟ್ ಟೈಮ್ ಒಂದ್ ಯಾವ್ದಾದ್ರು ಪೇಷಂಟ್ ಬಂದಾಗ ಅವ್ರದ್ದೆಲ್ಲ ಹಿಸ್ಟ್ರಿ ತಗೊಂಡ್ಬಿಟ್ಟು ಅವ್ರಿಗೆ ಏನಾದ್ರು ಕಾಯಿಲೆ ಇದೆನಾ, ಅವ್ರಿಗೆ ಏನಾದ್ರು ಮೆಡಿಕಲ್ ಹಿಸ್ಟ್ರಿ ಇದೆನಾ, ಸರ್ಜಿಕಲ್ ಹಿಸ್ಟ್ರಿ ಇದೆನಾ, ಯಾವ್ದಾದ್ರು ರಿಯಾಕ್ಷನ್ಸ್ ಇದೆನಾ, ಅಥವಾ ಕಂಜನೈಟಲ್ ಡಿಸೀಸ್ ಮನೆಯಲ್ಲಿ ಇದೆನಾ, ಈ ರೀತಿ ಎಲ್ಲ ನಾವು ಪ್ರೆಗ್ನೆನ್ಸಿನಲ್ಲಿ ಕೇಳ್ತೀವಿ ಎಲ್ರಿಗೂ. ಅಲ್ಲದೆ ಅವ್ರಿಗೆ ಏನಾದ್ರು ನಾವು ಚೆಕಪ್ ಮಾಡಿದಾಗ ಈಗ ರೆಸ್ಪಿರೇಟರಿ ಸಿಸ್ಟಮ್ ಆಸ್ಕಲ್ಟೇಷನ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಅಂದ್ರೆ ಬ್ರೆತ್ ಸೌಂಡ್ ಸರಿ ಇದೆನಾ ಅಥವಾ ಏನಾದ್ರು ಅಡಿಷನಲ್ ಸೌಂಡ್ಸ್ ಅಸ್ತಮಾ ತರ ಸೌಂಡ್ಸ್ ಕಾಣ್ತಾ ಇದೆನಾ ಅಂತ ಅಲ್ಲೇ ಗೊತ್ತಾಗುತ್ತೆ ನಮ್ಗೆ. ಅಷ್ಟೇ ಅಲ್ಲದೆ ಹಾರ್ಟ್ ಬೀಟ್ ಚೆಕ್ ಮಾಡಿದಾಗ ನಾವು ಸ್ಟೆಥೋಸ್ಕೋಪ್ ಹಾರ್ಟ್ ಅಲ್ಲಿ ಹಾಕಿದಾಗ ಅಡಿಷನಲ್ ಸೌಂಡ್ಸ್ ಇದ್ದಾಗ ಇವ್ರಿಗೆ ಏನಾದ್ರು ಕಾಯಿಲೆ ಇದೆನಾ ಅಂತ ಒಂದು ಸಂಶಯ ಬಂದಾಗ ನಾವು ಪೇಷಂಟ್ ಇಂದ ನಾವು ಕ್ಲಾರಿಫೈ ಮಾಡ್ಕೋಬಹುದು ವೆದರ್ ದೇ ಹ್ಯಾಡ್ ಅ ಹಾರ್ಟ್ ಡಿಸೀಸ್ ಅಂಡ್ ವೆದರ್ ದೇ ಆರ್ ಅಂಡರ್ಗೋಯಿಂಗ್ ಎನಿ ಟ್ರೀಟ್ಮೆಂಟ್. ಬಟ್ ಅನೇಮಿಯಾ ಇದ್ದಾಗ ನಾವು ಕೊಡೋ ಟ್ರೀಟ್ಮೆಂಟ್ ಇಂದ IV ಟ್ರೀಟ್ಮೆಂಟ್ ಇಂದಾಗ್ಲಿ ಅಥವಾ ಇಂಜೆಕ್ಟಬಲ್ ಆಗ್ಲಿ ಅಥವಾ ಇಂಟ್ರಾಮಸ್ಕ್ಯುಲರ್ ಆಗ್ಲಿ ಅಥವಾ ಓರಲ್ ಆಗ್ಲಿ ಯಾವ ತರ ಹಾರ್ಟ್ ಡಿಸೀಸ್ ಹೆಚ್ಚಿಗೆ ಆಗೋದಿಲ್ಲ ಅಥವಾ ಎಕ್ಸಾಜರೇಟ್ ಆಗೋದಿಲ್ಲ ಅಥವಾ ಪ್ರಿಸಿಪಿಟೇಟ್ ಆಗೋದಿಲ್ಲ. ಡೆಫಿನೆಟ್ಲಿ ಇಟ್ ವಿಲ್ ಬಿ ಅ ನಾರ್ಮಲ್ ಫೈಂಡಿಂಗ್. ಅರ್ಥ ಆಯ್ತು ಅನ್ಸುತ್ತೆ ನಿಮ್ಗೆ ಇವತ್ತು.
ಆಗಿರುತ್ತೆ ಮೇಡಮ್.
Let them put in the chat box whether they have
Dr.
understood or
Dr.
not.
Dr. Veena Bhatt ma'am has sent in the Q&A that she is willing to translate the whole talk in Kannada.
Very nice.
Definitely, yeah, nice.
Dr.
So,
Veena Bhatt ma'am.
Can we move to the next session? Or will she translate?
Madam, you are waiting for translation.
Dr. Veena Bhatt ma'am, is she there in the faculty link?
Yeah, she is there. Madam.
Shobha,
I've
can
sent
you
her
ask?
Yeah.
Can you ask one healthcare worker from any facility, at least two, to join? Any two?
Rajeshri, what about your facility? They were supposed to join?
No, I told Shobha that they are not prepared today for diabetes.
No, it's okay. It's okay if they are, even if they are not prepared.
Whatever
No
they have
worries.
understood, they let them join.
No worries. Ask them to join.
Facilities you call now.
Shobha, you call two participants from your facility and two from the facility.
I'll call madam.
Many of the attendees have raised their hands. Many of the attendees have raised their hands.
They have raised their hands. Rajeshri, you call your two staff.
Next, so those who have raised their hands, get their names and let them join. Let them join. Just let us check.
Let them join.
Madam, ಅಲ್ಲಿವರೆಗ ಇದು ಕನ್ನಡದ ಹೇಳೋಣ. ವೀಣಾ ಮೇಡಮ್ ಇದ್ದೀರಾ? ವೀಣಾ ಮೇಡಮ್ ಇದ್ದೀರಾ?
But let her open her video and start in Kannada.
ಇಲ್ಲ ವೀಣಾ ಮೇಡಮ್ ಲೇಟ್ ಆದ್ರೆ I'll start the first one. Madam can do the second one. Madam is there. Veena madam?
Dr. Rashri has translated. I think which part she has translated?
The complication.
Yes, translated only reactions.
Okay.
Veena madam?
Just take 5 minutes and translate everything in Kannada. Both the talks.
If you want, okay. I can screen share that treatment protocol. I can screen share that.
Yeah, that is better. You share so simultaneously they can see and Veena will translate. Please share that one.
I'll share that one. I'll just share that one.
I have the PPT. Yeah, madam.
Yes, madam. I will talk.
Okay, madam. Do it. Madam, we will introduce you first, Veena madam.
Okay,
we will introduce.
I am Dr. Veena Bhatt, practicing OB-GYN from last 29 years in Bhadravati. And
madam, we will introduce you.
Okay.
Jyoti madam, please introduce
Dr. Veena madam. Dr. Veena Bhatt is a prolific writer and she has written many medical books in Kannada. and she's a yoga expert, a teacher, and a social worker. As she said, she's a practicing OBGYN in Bhadravati, and she has translated even the KSOGA booklet, Vistrit booklet, along with Dr. Shobha in Canada. And she is a writer in writing columns in popular newspapers. Welcome to you, Dr. Veena, and our health workers will be greatly benefited by your translation.
ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್. ತುಂಬಾ ಧನ್ಯವಾದಗಳು ನನ್ನನ್ನ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಸೇರಿಸ್ಕೊಂಡಿದ್ದಕ್ಕೆ. ಇವತ್ತು ಡಾಕ್ಟರ್ ನಿವೇದಿತಾ ಅವರು ಓರಲ್ ಐರನ್ ಥೆರಪಿ ಅಂದ್ರೆ ಬಾಯಿಂದ ಕಬ್ಬಿಣಾಂಶ ಮಾತ್ರೆಗಳನ್ನ ತೆಗೆದುಕೊಳ್ಳೋದು, ಈ ಕಬ್ಬಿಣಾಂಶ ಕೊರತೆಯ ಒಂದು ರಕ್ತಹೀನತೆಯಲ್ಲಿ ಯಾವ ರೀತಿ ನಾವು ಹೊರರೋಗಿ ವಿಭಾಗದಲ್ಲಿ ತುಂಬಾ ಜನ ಇರ್ತಾರೆ, ಅವರಿಗೆ ಅದನ್ನ ಮಂದಟ್ ಮಾಡ್ಕೊಳಕ್ ಆಗಲ್ಲ, ಆದ್ರೆ ಅದು ಬಹಳ ಮುಖ್ಯ ಅಂತ ಹೇಳಿದ್ರು. ಈ ಒಂದು ಇದು ಹಿಮೋಗ್ಲೋಬಿನಿಯಪತಿ ಅಂತಹ ಕಾಯಿಲೆಯಲ್ಲಿ ಇದು ಬರಲ್ಲ. ಹಾಗಾಗಿ ಕಬ್ಬಿಣಾಂಶ ಕೊರತೆ ಅನಿಮಿಯಾ ಇದೆ ಅಂತ ಮೊದಲು ಖಚಿತವಾಗಿ ಡಯಾಗ್ನೋಸಿಸ್ ಅಥವಾ ಪತ್ತೆ ಮಾಡ್ಕೋಬೇಕು. ಅದನ್ನ ಓರಲಿ ಅಥವಾ ಆಹಾರದ ಮೂಲಕನೂ ಕಬ್ಬಿಣಾಂಶ ಕೊರತೆ ಸರಿಪಡಿಸಬಹುದು. ಆದ್ರೆ ನಮ್ಮ ಆಹಾರ ಸೇವನೆ ಅಷ್ಟು ಚೆನ್ನಾಗಿರಲ್ಲ, ಹಸಿರು ಸೊಪ್ಪು ತರಕಾರಿಗಳು ಇವನ್ನೆಲ್ಲ ಹೆಚ್ಚು ಸೇವಿಸೋದಿಲ್ಲ. ಹಾಗಾಗಿ ಓರಲ್ ಐರನ್ ಥೆರಪಿ ಬಹಳ ಮುಖ್ಯ. ಅದು ಕರ್ನಾಟಕ ಸರ್ಕಾರ ಇದು ಈಗ 11 ಗ್ರಾಮ್ಗಿಂತ ಹೆಚ್ಚಿದ್ದಾಗ ಕೂಡ ಪ್ರೊಫೈಲಾಕ್ಸಿಸ್ ಆಗಿ ಅಂದ್ರೆ ಮುಂಜಾಗ್ರತಾ ಕ್ರಮವಾಗಿ ಈ ಕಬ್ಬಿಣಾಂಶ ಮಾತ್ರೆಗಳನ್ನು ಕೊಡ್ಬೇಕು. ಕಡಿಮೆ ಇದ್ದಾಗಂತೂ ಕೊಡ್ಲೇಬೇಕು. ಅದು 12 ಗ್ರಾಮ್ ಇದ್ರೆ ನಮ್ಗೆ ಗರ್ಭಧಾರಣೆಯಲ್ಲಿ ಮಗುವಿಗೆ, ತಾಯಿಗೆ ಹಾಗೂ ಮಗುವಿಗೆ ತೊಡಕಾಗುವುದು ಕಡಿಮೆ ಆಗತ್ತೆ. ಈ ಭಾರತ ಸರ್ಕಾರ ಕೊಡ್ತಿರೋ ಐರನ್ ಫೋಲಿಕ್ ಆಸಿಡ್ IFA ಮಾತ್ರೆಯಲ್ಲಿ 60 ಮಿಲಿಗ್ರಾಮು ಎಲಿಮೆಂಟಲ್ ಐರನ್ ಇರುತ್ತೆ, ಮತ್ತೆ 0.5 ಮಿಲಿಗ್ರಾಮ್ ಫೋಲಿಕ್ ಆಸಿಡ್ ಮಾತ್ರೆಗಳಿರುತ್ತೆ. ಶಾಲೆಗಳಲ್ಲಿ, ಕಾಲೇಜ್ಗಳಲ್ಲಿ ಅದನ್ನ ಪ್ರೊಫಿಲಾಕ್ಟಿಕ್ ಆಗಿ ವಾರಕ್ಕೊಮ್ಮೆ ಕೊಡ್ತಾರೆ. ಹಾಗೆ ಇದು ಗರ್ಭಧಾರಣೆಯಲ್ಲಿ ಯಾವ ತರ ಕೊಡ್ಬೇಕಂತ ಹೇಳಿದ್ರೆ ಇದನ್ನ ಕನಿಷ್ಠ 180 ದಿನ ಕೊಡ್ಬೇಕು. ಮತ್ತೆ ರಕ್ತಹೀನತೆ ಇದ್ರೆ ಅಂದ್ರೆ ಮೈಲ್ಡ್ ಟು ಮಾರೇಟ್ ಸ್ವಲ್ಪ ತರ ರಕ್ತಹೀನತೆ ಇದ್ರೆ ಆವಾಗ ದಿನಕ್ಕೆ 2 ಮಾತ್ರೆಯನ್ನ ಕೊಡಬೇಕು, ಐರನ್ ಮಾತ್ರೆ, ಫೋಲಿಕ್ ಆಸಿಡ್. ಅದಕ್ಕೂ ಮೊದಲು 14 ವಾರದ ನಂತರ ಪ್ರತಿಯೊಬ್ಬ ಮಹಿಳೆಗೂ, ಗರ್ಭಿಣಿ ಸ್ತ್ರೀಯರಿಗೆ ಜಂತು ಹುಳ ನಿವಾರಣಾ ಮಾತ್ರೆ ಆಲ್ಬೆಂಡಜೋಲ್ 400 ಮಿಲಿಗ್ರಾಮ್ ಮಾತ್ರೆಯನ್ನ ಎಲ್ಲರಿಗೂ ಕೊಡ್ಬೇಕು. ಮತ್ತೆ ರಕ್ತಹೀನತೆ ಇದ್ರೆ ದಿನಕ್ಕೆ 2 ಮಾತ್ರೆಯನ್ನ ಕೊಡ್ಬೇಕು. ಯಾವಾಗ ಕೊಡ್ಬೇಕು? ಕಾಫಿ ಟೀ ಎಲ್ಲ ತಗೊಂಡು ಮಾತ್ರೆಯನ್ನ ತಗೊಳ್ಬಾರ್ದು. ಯಾಕಂದ್ರೆ ಅದರಲ್ಲಿ ಟ್ಯಾನಿನ್ ಅಂಶ ಕಬ್ಬಿಣಾಂಶ ಹೀರುವಿಕೆಯನ್ನ ತಡೆಗಟ್ಟುತ್ತೆ. ಫೈಟೇಟ್ಸ್, ದೋಸೆ, ಚಪಾತಿ ಇದೆಲ್ಲ ತಿನ್ಬಾರ್ದು. ಮತ್ತೆ ಕ್ಯಾಲ್ಸಿಯಂ ಮಾತ್ರೆ ಜೊತೆ ಕಬ್ಬಿಣಾಂಶ ಮಾತ್ರೆಯನ್ನು ಕೊಡ್ಬಾರ್ದು. ಹಾಲು, ಹಾಲಿನ ಉತ್ಪನ್ನ ಎಲ್ಲ. ಸೊ ಹಾಗಾಗಿ ಯಾವ ರೀತಿ ಇದು ಮೊದಲ ಒಂದು ಈ ತೀವ್ರತೆ, ರಕ್ತಹೀನತೆಯ ತೀವ್ರತೆ ಯಾವ ರೀತಿ ಇದೆ ಅಂತ ಹೇಳಿ, ಅಂದ್ರೆ ಮಾಡರೇಟ್ ಮತ್ತೆ ಮೈಲ್ಡ್, ಸ್ವಲ್ಪ ಮಟ್ಟು ಹಾಗೆ ಮಂದಗತಿಯಲ್ಲಿರುವ ರಕ್ತಹೀನತೆಗೆ ಮಾತ್ರ ಈ ಕಬ್ಬಿಣಾಂಶ ಮಾತ್ರೆ ಕೊಡ್ಬಹುದು. ತೀವ್ರತೆ ಇದ್ರೆ ಅದಕ್ಕೆ ರಕ್ತ ಹಾಕ್ಲೇಬೇಕು, ರಕ್ತ ಪೂರೈಕೆ ಅಥವಾ ಬ್ಲಡ್ ಟ್ರಾನ್ಸ್ಫ್ಯೂಷನ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಸೊ ಹಾಗಾಗಿ ಈ ಒಂದು ಚಾರ್ಟ್ ಅನ್ನ ಎಕ್ಸ್ಪ್ಲೇನ್ ಎಂಡಲ್ ಮಾಡ್ಲಾ ಮೇಡಮ್ ನಾನು?
ಇಲ್ಲ, ಇವಾಗೆ ಮಾಡ್ಬಿಡಿ. ಕ್ಲೋಸ್ ಇಟ್ ಆಫ್ಟರ್ ಎಕ್ಸ್ಪ್ಲನೇಷನ್.
ಓಕೆ. ಸೊ ಇದು ರಕ್ತಹೀನತೆ 5 ಗ್ರಾಮ್ಗಿಂತ ಕಡಿಮೆ ಇದ್ದಾಗ ಅದು ತೀವ್ರತರವಾದ ರಕ್ತಹೀನತೆ. ಅವಾಗ ಯಾವುದೇ ಹಂತದ ಗರ್ಭಿಣಿ ಆದ್ರೂ ಅವಾಗ ರಕ್ತವನ್ನು ಹಾಕ್ಬೇಕಾಗುತ್ತೆ, ಬ್ಲಡ್ ಟ್ರಾನ್ಸ್ಫ್ಯೂಷನ್ ಮಾಡ್ಬೇಕಾಗತ್ತೆ. ಇಲ್ಲ ಅದು ಸ್ವಲ್ಪ 5 ರಿಂದ 7 ಗ್ರಾಮ್ ಇತ್ತು ಅಂತ ಹೇಳಿದ್ರೆ ತಕ್ಷಣ ಆಸ್ಪತ್ರೆಗೆ ಅಡ್ಮಿಟ್ ಮಾಡ್ಬೇಕಾಗತ್ತೆ, ರಕ್ತ ಪೂರೈಕೆಯನ್ನ ಮಾಡ್ಬೇಕಾಗತ್ತೆ ಯಾವುದೇ ಹಂತದಲ್ಲಿ ಇದ್ದಾಗ. ಅದು ಇನ್ನು 5 ರಿಂದ 7 34 ವಾರಗಳ ಒಳಗಿದ್ರೆ ಆವಾಗ ಎಲ್ಲಾ ಕಡೆ ಸೌಲಭ್ಯ ಇರೋ ಆಸ್ಪತ್ರೆಗಳಲ್ಲಿ ಅವರನ್ನ ರೆಫರ್ ಮಾಡಿ ಅವರಿಗೆ ಪ್ಯಾರೆಂಟ್ರಲ್ ಐರನ್ ಅಥವಾ ಇಂಜೆಕ್ಟಬಲ್ ಐರನ್, ಕಾರ್ಬಾಕ್ಸಿ ಮಾಲ್ಟೋಸ್ ಅಥವಾ ಐರನ್ ಶುಕ್ರೋಸ್ ಅದನ್ನ ವೈದ್ಯರು ನಿರ್ಧಾರ ಮಾಡಿ ಕೊಡ್ತಾರೆ. ಮತ್ತೆ 34 ವಾರದ ನಂತರ ಈ ತೀವ್ರತರವಾದ ರಕ್ತಹೀನತೆ ಇದ್ರು ಅಥವಾ 5 ರಿಂದ 7 ಗ್ರಾಮ್ ರಕ್ತ ಇದ್ರೆ ತಕ್ಷಣ ಆಸ್ಪತ್ರೆಗೆ ಅಡ್ಮಿಟ್ ಮಾಡ್ಬೇಕಾಗತ್ತೆ. ಇನ್ನು ಹಿಮೋಗ್ಲೋಬಿನ್ 10 ರಿಂದ 11 ಒಳಗೆ ಅಂದ್ರೆ 10.9 ಇದ್ದಾಗ, ಅದು 34 ವಾರಗಳ ಮೇಲಿದ್ದಾಗ ಮಾಡ್ಬೇಕಂತ ಹೇಳಿದ್ರೆ ಆವಾಗ ರಕ್ತ ಐರನ್ ಶುಕ್ರೋಸ್ ಇಂಜೆಕ್ಷನ್ ಅನ್ನ ಕೊಡ್ಬೇಕಾಗತ್ತೆ. ಮತ್ತೆ ಅದು ಹೇಗೆ ಗೊತ್ತಾಗುತ್ತೆ ಅದು ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಆಗ್ತಾ ಇದೆಯೋ ಇಲ್ವೋ, ರಕ್ತಹೀನತೆ ಸರಿಪಡಿಸ್ತಾ ಇದೆಯೋ ಇಲ್ವೋ ಅಂತ ನೋಡ್ಲಿಕ್ಕೆ 1 ಗ್ರಾಮ್ ಪರ್ಸೆಂಟೇಜ್ ಆದ್ರೂನು 1 ತಿಂಗಳಾದ್ಮೇಲೆ ಜಾಸ್ತಿ ಆಗ್ತಾ ಹೋಗ್ಬೇಕು. ಅದು ಆಗ್ಲಿಲ್ಲ ಅಂತಂದ್ರೆ ಮತ್ತೆ ನೀವು ಆ ಕೇಸನ್ನ ರೆಫರ್ ಮಾಡ್ಬೇಕಾಗತ್ತೆ. ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಆಗ್ತಾ ಹೋಯ್ತು ಅಂತ ಹೇಳಿದ್ರೆ ಆವಾಗ ಅದು ಇಂಜೆಕ್ಷನ್ ಕೊಟ್ಟ ಆದ್ಮೇಲೆ ಮತ್ತೆ ಯಾವುದೇ ಒಂದು ಮಾತ್ರೆಗಳನ್ನ ಕೊಡೋ ಅಗತ್ಯ ಬರಲ್ಲ. ಅಷ್ಟೇ ಅಲ್ಲ, ಅದು ಏನಾದ್ರೂ 34 ವಾರದ ಒಳಗಿದ್ರೆ ಅದನ್ನ ಮತ್ತೆ ಈ ಮಾತ್ರೆಗಳನ್ನೇ ಕೊಡ್ಬೇಕಾಗತ್ತೆ. ಇನ್ನು 34 ವಾರದ ಒಳಗೆ ಇದ್ದು ಅವರು ಮಾತ್ರೆಗಳನ್ನ ತೆಗೆದುಕೊಳ್ಳೋ ಸಾಧ್ಯತೆ ಇದೆ ಅಂತ ಆದ್ರೆ ಆವಾಗ ದಿನಕ್ಕೆ 2 ಮಾತ್ರೆ ಐರನ್ ಫೋಲಿಕ್ ಆಸಿಡ್ ಅನ್ನ ಕೊಡ್ಬೇಕು. ಮತ್ತೆ ಅದರಲ್ಲಿ ಹೇಗೂ ಫೋಲಿಕ್ ಆಸಿಡ್ ಮಾತ್ರ 500 ಮೈಕ್ರೋಗ್ರಾಮ್ ಅಥವಾ 0.5 ಮಿಲಿಗ್ರಾಮ್ ಇರುತ್ತೆ. ಇವರಿಗೆ ಯಾವುದೇ ರೀತಿಯ ಉತ್ತಮ ಆಗಿಲ್ಲ, ಮಾತ್ರೆಗಳನ್ನ ತಗೊಂಡ್ರು 1 ಗ್ರಾಮ್ಗಿಂತ ಜಾಸ್ತಿ ಆಗಿಲ್ಲ ಅಂದ್ರೆ ಆವಾಗ ಮತ್ತೆ ನಾವು ಬೇರೆ ಆಸ್ಪತ್ರೆಗೆ ರೆಫರ್ ಮಾಡ್ಬೇಕಾಗತ್ತೆ. ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಆಗ್ತಾ ಇದೆ ಅಂದ್ರೆ ಇದನ್ನ ಕಂಟಿನ್ಯೂ ಮಾಡ್ಬೇಕಾಗತ್ತೆ. ಮತ್ತೆ ಇದು ಮುಖ್ಯ ಏನಂತ ಅಂದ್ರೆ ಜಾಸ್ತಿ ಆಗ್ತಾ ಇದೆಯೋ ಇಲ್ಲೋ ಅನ್ನೋದನ್ನ ಪರೀಕ್ಷೆ ಮಾಡೋದು ಬಹಳ ಮುಖ್ಯ. ಯಾಕಂದ್ರೆ ಹಿಮೋಗ್ಲೋಬಿನೋಪತಿಯಂತಹ ತೊಂದರೆ ಇದ್ದಾಗ ಈ ರೀತಿಯಾಗಿ ಅದು ರಕ್ತ ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಆಗದೆ ಇರಬಹುದು. ಮತ್ತೆ ಇಷ್ಟೇ ಅಲ್ಲ, ನೀವು ಡೆಲಿವರಿ ಮಾಡಿದ ಮೇಲೂ ಕೂಡ ಡಿಸ್ಚಾರ್ಜ್ ಆಗೋ ಮೊದಲು ಹಿಮೋಗ್ಲೋಬಿನ್ ಅನ್ನ ಪರೀಕ್ಷೆ ಮಾಡಿಸ್ಲೇಬೇಕು. ವಿಶ್ವ ಆರೋಗ್ಯ ಸಂಸ್ಥೆ ಗೈಡ್ ಲೈನ್ ಪ್ರಕಾರ 10 ಗ್ರಾಂ% ಇರಲೇಬೇಕು. ಅದಕ್ಕೋಸ್ಕರ ಅವರಿಗೂ ಕೂಡ 180 ಮಾತ್ರೆಗಳನ್ನ ಕೊಟ್ಟು ಕಳಿಸ್ಬೇಕು ಎಲ್ರಿಗೂ. ಯಾಕಂದ್ರೆ ಇದು ಬಹಳ ಮುಖ್ಯ. ಹೆರಿಗೆ ಆದ್ಮೇಲೆ ಸ್ತನ್ಯಪಾನ ಚೆನ್ನಾಗ್ ಆಗ್ಬೇಕು, ಮಗು ಬೆಳವಣಿಗೆ ಮತ್ತೆ ತಾಯಿಗೆ ಆಗಿರೋ ಸುಸ್ತು ಇವೆಲ್ಲ ತೊಡಕುಗಳನ್ನ ತೊಂದರೆ ಅಂದ್ರೆ ಸೋಂಕಾಗಬಹುದು. ನಿಮ್ಮ ಬರೀ ರಕ್ತಹೀನತೆ ಮಾತೃ ಮರಣಕ್ಕೆ 20% ಕಾರಣ ಆಗುತ್ತೆ, ಡೈರೆಕ್ಟ್ಲಿ ಇಂಡೈರೆಕ್ಟ್ಲಿ. ಅಷ್ಟೇ ಅಲ್ಲ, ಹಲವಾರು ತೊಡಕು ಸೋಂಕಾಗಬಹುದು, ಸ್ತನ್ಯಪಾನ ಸರಿ ಆಗದೆ ಇರಬಹುದು, ಬೇರೆ ಬೇರೆ ಸಮಸ್ಯೆಗಳಿಂದ ರಕ್ಷಿಸಲು ಹೆರಿಗೆ ಆದ್ಮೇಲೂ ಕೂಡ ಇದು ಕೊಡೋದು ಬಹಳಷ್ಟು ಮುಖ್ಯ ಅಂತ ಡಾಕ್ಟರ್ ನಿವೇದಿತಾ ಅವರು ತುಂಬಾ ಚೆನ್ನಾಗಿ ಹೇಳಿದ್ರು. ಮತ್ತೆ ಇದ್ರ ಸೈಡ್ ಎಫೆಕ್ಟ್ಸ್ ಬಗ್ಗೆ ಹೇಳೋದಿದ್ರೆ ಇದು ಏನಂದ್ರೆ ಇದು ಯಾವಾಗ ತಗೊಳ್ಬೇಕು ಐರನ್ ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ಅನ್ನ ಅಂತಂದ್ರೆ 2 ತಾಸು ಮೊದಲು ಅಥವಾ 2 ತಾಸು ನಂತರನೇ ತಗೊಳ್ಬೇಕು. ಊಟ ತಿಂಡಿ ಜೊತೆಗೆ ತಗೊಳ್ಬಾರ್ದು. ಮತ್ತೆ ಹೇಗೆ ಇದು ಎದೆ ಉರಿ, ವಾಂತಿ, ಬೇರೆ ಬೇರೆ ಸಲ ತೊಂದ್ರೆ ಆಗಬಹುದು. ಆದ್ರೂ ಅದೆಲ್ಲ ಸಣ್ಣ ಪುಟ್ಟದಿದ್ರೆ ಪೇಷಂಟಿಗೆ ಸಮಾಧಾನ ಮಾಡಿ ಇವೆಲ್ಲ ದೊಡ್ಡ ತೊಂದ್ರೆ ಅಲ್ಲಮ್ಮ ಅಂತ ಹೇಳ್ಬೇಕು. ಕೆಲವರಿಗೆ ಮಲಬದ್ಧತೆ ಆಗುತ್ತೆ, ಅವಾಗ ಏನ್ ಮಾಡ್ಬೇಕು, ನೀರು ಅಂತ ಹೇಳ್ಬೇಕು. 4 ಲೀಟರ್ ನೀರ್ ಕುಡಿಬೇಕು. ತುಂಬಾ ಚೆನ್ನಾಗಿ ಸಪ್ಪಿನಾಂಶ ಅಂದ್ರೆ 30 ಗ್ರಾಮ್ ಆದ್ರೂ ದಿನಕ್ಕೆ ಫೈಬರ್ ಕಂಟೆಂಟ್ ಅನ್ನ ತಗೋಬೇಕು. ಎಲ್ಲಾ ರೋಗಿಗಳಿಗೂ ನೀರು ಸರಿ ಇದ್ರೆ ಮಲಬದ್ಧತೆ ಆಗಲ್ಲ ಅಂತ ಹೇಳ್ಬೇಕು. ಮತ್ತೆ ಇನ್ನು ಐರನ್ ಫೋಲಿಕ್ ಆಸಿಡ್, ವಿಟಮಿನ್ ಸಿ ಮಾತ್ರೆ ಜೊತೆ ತಗೊಂಡ್ರೆ, ಮಾತ್ರೆನೇ ಆಗ್ಬೇಕು ಅಂತಿಲ್ಲ, ಗೂಸ್ಬೆರಿ ಆಮ್ಲದಲ್ಲಿ ತುಂಬಾ ಇರುತ್ತೆ, ನಿಂಬೆ ಹಣ್ಣಲ್ಲಿ ಇರುತ್ತೆ, ಕಿತ್ಲೆ ಹಣ್ಣಲ್ಲಿ ಇರುತ್ತೆ. ಇವುಗಳ ಜೊತೆಗೆ ತಗೊಂಡಾಗ ಚೆನ್ನಾಗಿ ಈ ಕಬ್ಬಿಣಾಂಶ ಹೀರುವಿಕೆ ಆಗುತ್ತೆ ಅನ್ನೋದನ್ನ ರೋಗಿಗಳಿಗೆ ಚೆನ್ನಾಗಿ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡ್ಬೇಕು. ಮತ್ತೆ ಹಸಿರು ಸೊಪ್ಪು ತರಕಾರಿಗಳನ್ನೆಲ್ಲ ಹೆಚ್ಚಿಗೂ ತಿನ್ಲಿಕ್ಕೆ ಹೇಳ್ಬೇಕು. ಹಾಗಾಗಿ ಇವೆಲ್ಲ. ಆಮೇಲೆ ಮೀಟು, ಮಾಂಸಾಹಾರದಿಂದ ಬಂದಿದ್ದು ಅಬ್ಸಾರ್ಬೆಬಲ್ ಹಿಮ್ ಐರನ್ ಅಂತ ಹಿಮ್ ಇದೆಯಲ್ಲ, ಅಂದ್ರೆ ಈ ಪೌಲ್ಟ್ರಿ, ಫಿಶ್, ಮೀಟು ಇದೆಲ್ಲ ತುಂಬಾ ಚೆನ್ನಾಗಿ ಹೀರುವಿಕೆ ಆಗತ್ತೆ. ಯಾವ್ದ್ರಿಂದ ಕಬ್ಬಿಣಾಂಶದ ಹೀರುವಿಕೆ ಆಗತ್ತೆ. ಇಷ್ಟು ಸಾಕಲ್ವಾ ಮೇಡಮ್? ಇದು
ಸಾಕು. You will answer their queries. It is excellent talk, Veena.
ಥ್ಯಾಂಕ್ ಯು ಮೇಡಮ್. ಮತ್ತೆ ಇನ್ನು ಈ ಮೇಡಮ್ ಹೇಳಿದ್ದು ಪ್ಯಾರೆಂಟ್ರಲ್ ಇದು ಹೇಳ್ಬೇಕಾ ಮೇಡಮ್? ಸ್ವಲ್ಪ
ಅದು ಪೇರೆಂಟಲ್ ಬೇಡ, ಇದಿಷ್ಟು ಹೇಳಿದ್ರೆ ಸಾಕು. ಪೇರೆಂಟಲ್ ರಾಜಶ್ರೀ ಸ್ವಲ್ಪ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡಿದ್ದಾರೆ ಹೇಗೆ ಕೊಡ್ಬೇಕು ಮತ್ತೆ ಎಲ್ಲ. ಸೊ ಶಿ ಹ್ಯಾಸ್ ಎಕ್ಸ್ಪ್ಲೇನ್ಡ್ ಇಟ್.
ಓಕೆ ಮೇಡಮ್, ಥ್ಯಾಂಕ್ ಯು.
Thank you, madam.
Thank you.
Unmute. Now we move on to the most exciting part of this session, the quiz related to these topics. The quiz masters are Dr. Veena and my co-convener, Dr. Anupam Singh. To introduce Dr. Anupam Singh, she is the member of the Safe Motherhood Committee of FOGSI from Jharkhand, and you have been the witness as how nicely she coordinated with such a good command on the language. Over to the quiz masters to conduct the quiz.
Thank you so much, ma'am. Is my screen visible?
Yes, ille maatre barutte banri.
Okay.
ಇಲ್ಲಿ ಬನ್ನಿ.
So I would be telling the questions asking the questions in English, and Veena ma'am, you please translate the questions in Kannada. So the first question is, what should be the minimum level of hemoglobin in pregnancy?
11 gram. ಹಿಮೋಗ್ಲೋಬಿನ್ ಮಟ್ಟ ಗರ್ಭಧಾರಣೆಯಲ್ಲಿ ಕನಿಷ್ಠ ಎಷ್ಟಿರ್ಬೇಕು?
11 ಗ್ರಾಮ್ ಮೇಡಮ್.
11 ಗ್ರಾಮ್.
Madam, my staffs are answering.
Yes,
Can
very
we-
good, very
11
good, very
gram.
good. Next, yes, perfect.
Yes,
Very
that's
good.
the correct answer. That is more than 11 gram per DL. Thank you. Now we move on to the next question. Deworming is not recommended in pregnancy at 12 weeks, 16 weeks, 28 weeks, 32 weeks.
The question is that deworming is done, but at this time it is not done. Which period is it not done?
ಯಾವ ಸಮಯದಲ್ಲಿ ಜಂತುಹುಳದ ಮಾತ್ರೆಗಳನ್ನ ಕೊಡಬಾರದು? 12 weeks ಗರ್ಭಧಾರಣೆಯಲ್ಲಿ.
Very good.
Very good, very good, perfect.
Correct answer. And we do it after 14 weeks with a single dose of albendazole, 400 milligrams. Moving on to the next question. Which one inhibits iron absorption? Seafood, fruits, milk, juices. Sorry.
Matlab, which one is may? May say the iron absorption becomes less. Less. It is milk.
ಯಾವ
Very good.
ಆಹಾರ ಕಬ್ಬಿಣದ ಹೀರುವಿಕೆಯನ್ನ ಕಡಿಮೆ ಮಾಡುತ್ತೆ? ಮಿಲ್ಕ್
ಹಾಲು ಮೇಡಮ್.
Very good, very good, very good, very good, very good.
What are the other things which inhibits iron absorption? Tea, coffee, phytates, milk, and milk products. Okay, so now we move on to the next question. After how many weeks hemoglobin estimation is done to see the response to iron therapy? 2 weeks, 4 weeks, 6 weeks?
4 weeks, ma'am. 4 weeks.
Very
Very good, very good, very good, excellent. Special prize.
Yeah, they don't even need the translation. Very good. Which is the correct? Now, a very important question. Which is the correct option regarding prophylactic dose of iron and folic acid in pregnancy?
Prophylactic means when the hemoglobin is more than 11
More than
grams.
11, yes. So first option is 1 tab of IFA, 60 milligram elemental iron plus 500 microgram folic acid daily for 120 days. 1 tab of iron folic acid, 80 milligram elemental iron plus 500 microgram folic acid daily for 180 days. 1 tab of iron folic acid, 60 milligram elemental iron plus 500 microgram folic acid daily for 180 days. Or 2 tabs of iron and folic acid, 60 milligram elemental iron plus 500 microgram of folic acids daily for 160 days.
One tab of iron folic acid, ma'am. 80 mg plus 500 mg daily, ma'am. 180 days. B option.
Then you just check. One is iron ka dose, how many tablets, then how much of elemental iron, and for how many days.
3 things are there.
ಇದು ರಕ್ತಹೀನತೆ ಇಲ್ಲ ಅಂದ್ರೂ ಮುಂಜಾಗ್ರತೆಯಾಗಿ ಕೊಡೋದು. ಇದು ಚಿಕಿತ್ಸೆಯಾಗಿ ಕೊಡೋದಲ್ಲ.
ಸಿ ಮೇಡಮ್.
60 mg, ma'am.
Okay.
Which option? Which option? Which option?
C option.
A, B,
ಸಿ.
C. Okay, very good.
Correct.
So it has to be very clear. 60 milligram elemental iron, 1 tablet daily for 180
1
days.
tab of iron folic acid, 60 milligram of elemental iron plus 500 microgram of folic acid daily for 180 days. That's the
And
answer.
please clarify, this has to be given in antepartum and also postpartum period.
Postpartum.
So during pregnancy, antenatally 180 days at least, and after pregnancy 180 days. That means for 6 months they have to take this.
So this is a prophylactic dose for both pregnancy and lactation. So moving on to the next, treatment of anemia in a patient with hemoglobin less than 5 gram per DL at 24 weeks of pregnancy is?
Blood transfusion.
Very good.
Very good.
It is price special.
To the answer. Yes. Severe anemia in all the trimesters is treated with blood transfusion. So now we move on to the next. Postpartum anemia is defined as hemoglobin less than 10 gram percent, less than 11 gram percent, less than 12 gram percent, and less than 13 gram percent.
Less than 10.
Very good.
Which option?
Less than 13. ಹೆರಿಗೆಯ ನಂತರ ಹಿಮೋಗ್ಲೋಬಿನ್ ಎಷ್ಟಿರಬೇಕು? WHO ವಿಶ್ವ ಆರೋಗ್ಯ ಸಂಸ್ಥೆ ಪ್ರಕಾರ
10 ಗ್ರಾಮ್.
Postpartum. Understand the question. Postpartum.
Yes, ma'am. Less than 10, ma'am. Less than
Very
10.
good.
Very good. That's the correct.
We are getting
Yes.
a lot of answers in the question answers also, and I can tell you that all of them are also correct.
And
Okay.
even in the group, they're answering.
Okay.
Very good. They could have come on the actual faculty link and answer.
Madam, I asked around 10 hospitals. Everybody
No,
told.
no, everybody is answering now in that group.
Okay.
Now
So,
they're answering
Care workers, they are answering.
what is the maximum dose of iron sucrose in 1 week according to Government of India guidelines? That is 1000 milligram, 100 milligram, 600 milligram, 800 milligram.
600.
Very good.
Very good.
Option.
Very good. Very
And
good.
how you give it? How you give it? How should you give it?
Here also
That is
they've all
also
answered
important.
600. They've given 600.
Beta,
Very good.
how
Even
you
given.
how you give it?
Ma'am, 100 ml NS saline with
10.
So you can give 200 milligram per day and give a gap of 1 day. That means in a week you can give three times. Okay, you can give 3 times.
All answers even in Q&A are correct.
Yes.
Okay.
What is not done in transfusion reaction? You do everything. What you don't do? Continue transfusion, oxygen mask to be applied, emergency tray should be ready, call the doctor on duty. Is that one thing that you do not do?
continue transfusion.
Very good. What do you do then?
ಆಕ್ಸಿಜನ್ ಹಾಕೋತೀವ್ರಿ ಮ್ಯಾಮ್, ಮತ್ತೆ ಎಮರ್ಜೆನ್ಸಿ ಟ್ರೇ ರೆಡಿ ಮಾಡಿರ್ತೀವಿ ಮ್ಯಾಮ್. ಡಾಕ್ಟರ್ಸ್ಗೆ ಇದ್ ಮಾಡ್ತೀವಿ, ಮತ್ತೆ ವೈಟಲ್ಸ್ ಎಲ್ಲ ನೋಡ್ಕೋತೀವ್ರಿ ಮ್ಯಾಮ್. ದೆನ್ IV ಕೆನುಲ್ ಹಾಕೋಕ್ಕಿಂತ ಮುಂಚೆ ಎಲ್ಲ ಮಟೀರಿಯಲ್ಸ್ ಎಲ್ಲ ಎಕ್ಸ್ಪೈರ್ ಆಗಿದಾವೆಲ್ಲ ಅಂತ ಬಿಫೋರ್ ನೋಡ್ಕೋತೀವ್ರಿ.
And stop the transfusion.
What we understand.
ಅದನ್ನ ನಿಲ್ಸ್ಬೇಕು. ಟ್ರಾನ್ಸ್ಫ್ಯೂಷನ್ ಬಂದ್ ಮಾಡ್ಬಿಡ್ಬೇಕು. ಬಂದ್ ಮಾಡ್ಬಿಟ್ಟು ನೀವು ಎವಿಲ್ ಮತ್ತೆ ಡೆಕ್ಸ್ಟೋನ ಇದನ್ನ ಇಲ್ಲ ಕೈಯಲ್ಲಿ ನೋಡ್ಕೋಬೇಕು. ಟ್ರಾನ್ಸ್ಫ್ಯೂಷನ್ ಸ್ಟಾಪ್ ಮಾಡ್ಬಿಡ್ಬೇಕು.
Okay. So the next question is, which oxytocic is contraindicated in severe anemia? Oxytocin, misoprostol, carboprost, and methergin. What is that one which you do not give in severe anemia?
Methergin.
Very good.
Very good. Very good.
Acha, just hold on. What are the other contraindications for use of methergin? No, that's important to know. Yeah.
Ma'am, please translate. Veena, ma'am, please translate the question.
Veena, ma'am, please translate. What are the other contraindications?
ಮೆಥರ್ಜಿನ್ ಅನ್ನ ಇನ್ನು ಯಾವ ಕಂಡೀಷನ್ ಅಲ್ಲಿ ಕೊಡಲ್ಲ ನಾವು. ಅನಿಮಿಯಾ, ಈ ತೀವ್ರತರವಾದ ಅನಿಮಿಯಾ ಬಿಟ್ಟು.
Very good. Hypertension. Very good. What else? What else?
One more. Very important.
Pre-eclampsia.
Is hypertension.
Is hypertension.
ಹಾರ್ಟ್ ಅಂದ್ರೆ ತುಂಬಾ ಇಷ್ಟ ಅವರಿಗೆ.
Hypertension. What will happen to heart if there is a hypertension? Heart failure. If there is a congestive heart failure or cardiac problem, you should avoid using methergin. Okay. So 3 contraindications for use of methergin. One is severe anemia. Second one is hypertension. And what is the third one is the cardiac problems. Okay. Okay. Very good. I think Shobha, you just asked 2 people because it's very easy now to get the responses. When they stand in group and they start talking, then it is very difficult for us to understand.
Correct, madam.
Ma'am, we are done with the questions.
So thank you so much. A big round of applause to both these young girls.
Fantastic. And even
And
the
those
Q&A
also
they were
should be appreciated that they have joined online and they have answered also in chat box.
Responded on the chat box. Yes.
Absolutely, ma'am. Absolutely.
Yeah,
But
35
I would
people
also.
have answered, madam, actually.
So many people answered.
So many people have answered. So many. I
But
would
they are
Shobha,
not ready to
please,
join online.
Shobha,
So
please
bad.
ensure that they join online.
Madam, what we will do is we'll just call them then and there only. That is better, madam.
No. They should be ready. They should be prepared actually to
No,
join.
one
Otherwise,
facility we are tackling, no? So one
it will
facility should be
spoil
ready.
your quiz time. It will spoil your quiz time if you are not prepared from the beginning.
Because actually I had asked 3 people, madam. Finally,
Shobha, I'll tell you what. Hello, Shobha. You just put it in you put it in the group of healthcare workers. If the facility is not working, now you put in a group of health workers, and the first 3 names which come out, or first 4 names which come out, you take them on with the facility.
Madam,
So that
who were ready yesterday. 2 facilities were ready, but they told they're very busy with OTs and labels. That's why they moved on.
They have done very well. They have done very well.
Nivedita, two facilities joined in the last meeting also, but they were, I think, 8 or 10 people. You just can call 2 of them. They are eager to learn. So call 2 of them. So gradually it will build up interest. So next session people will join then.
Okay.
And no, you can keep 2 standby also. अभी दोनों फैसिलिटी को ओटी कैसे आता है? ऐसा होता है ना कि 2 फैसिलिटी स्टैंड
My hospital is standby.
Always it is standby because there only वो मान्यता भी हो गया, सभी हो गया. They will go on answering. We want to reach outreach the other people, no, Shobha.
No, standby only, madam.
That is not, our aim is different. Aim and
we also want that the other people, like your staff are very good. They're doing very well. They are getting the accolades also, and there are a lot of people who are answering, but they are not coming on the faculty link. We can't see them.
So we have to motivate them to join.
Also want to see them. Because there are lots of people who have answered.
Many people told, madam, they will join next time. At least 5 facilities have told they will join next time.
Just
5. Okay,
next time they will do makeup and all. They'll not look anemic and they will join.
So I think we are done with this session today.
Yes. Yeah, as we sail to the end of this program, it is my proud privilege to deliver the vote of thanks. At the outset, I thank Dr. Vidya Tobi Madam for taking up this program for Karnataka to bring a change in the healthcare system. My sincere thanks goes to Dr. Preeti Kumar, the backbone of this program, who also wants to bring about a revolution in healthcare system through mentoring the healthcare workers. I thank Dr. Rajeshri Palladi for all the tips and tricks given to the healthcare workers and summing up so efficiently. Thank you, Dr. Falgun Shah and Dr. Kasturi Donimat for showering your blessings. My sincere thanks again to Dr. Nivedita and Dr. Meeta Gupta for giving such a wonderful lecture, for so much of clarity and so much of clarifications you have brought about, and all the confusions have been erased. Dr. Veena Bhatt, madam, you have so nicely translated in the quiz into Kannada, and so our students, our healthcare workers could understand it so well and give wonderful responses. Dr. Anupam Singh, my co-coordinator, thank you so much. You have become my friend and you have coordinated with me so well. My immense thanks goes to Dr. Shobha. She is the chairperson of the Safe Motherhood Committee of KSOGA. As rightly said, she is a very quiet person, efficient person, working quietly at the background and who is responsible also for the success of this program. And my thanks to Dr. Suman Goody, the treasurer of KSOGA. And my sincere thanks also goes to all the healthcare facilities. They have put so much of trust and faith on this program, and they have enrolled for this program. My thanks, dear healthcare workers, for joining in this program and learning through our mentors. I thank Walter Bushnell for giving us this platform. Thank you one and all for this program.
Thank you, Jyoti. Thank you for wonderfully coordinating this session.
Thank you,
so
madam.
Our next session would be on 7th. The time will remain the same, 3:30 p.m. to 5 p.m. Next 2 sessions would be on diet counseling, that will be taken by Dr. Shobha, and another talk would be on blood transfusion. So that both the talks would be in Kannada. So I request everyone to please join, because it would be in your local language. We might be busy in Husur Gestosis conference, but all the best. The link will be created by Walter Bushner and Dr. Vidya and Dr. Rashi and Dr. Shobha, and Dr. Vidya Chaudhary from Safe Motherhood Committee will join to support you all. So thank you so much. And I think with this, we can close the session. Thank you, Firoz. Firoz, are you there?
Yes, ma'am. Yes, ma'am. I'm there. I'm there.
Thank you so much, Walter Bushner, for providing the link.
Thank you. Thank you,
Thank
one
you
and
so much,
all.
ma'am. It's an honor for us.
The links have been shared. The recording of the 2 sessions have been sent on mail. Please check that. I have also put it on the group, so you can circulate to the members.
Thank you so much. Thank you. Thank you, Preeti.
I would take just 1 minute to, first of all, thank Preeti ma'am for all the opportunities that she has given to each one of us to hone our abilities and potential. And I would also like to thank the Karnataka OBGYN Society and all my co-conveners, especially Dr. Jyoti ma'am, and all the dignitaries from Karnataka Society. It was a great pleasure hosting this session. It was an absolutely wonderful session. And I would, in fact, promise you all that I would learn reasonable Kannada. Hopefully when we meet the next time, I'll be able to
Yes. If you
Kannada,
know
a
Sanskrit,
little bit of
you
Kannada.
will learn any language.
You're a good quiz master, Anupam Singh.
Thank you so much.
Yes,
ma'am.
yes,
Thank you
always.
so much.
Fantastic.
Nivedita and Meeta, well done.
Thank you. Thank you.
Thank you so much, Dee, for giving us the honor. Thank you.
वो तो पता तब चलेगा जब इनका assessment होगा, mentoring.
Assessment अच्छा होगा. Assessment अच्छा होगा.
No, madam, honor staffs are very good. All the healthcare workers, they're interested because they're all so busy. Even then they've joined. I called up at least 15 hospitals. Everybody had OTs waiting, labors waiting. Even then, at least 80 to 90 people logged in and 20 people were watching in YouTube.
Good. Very good. Thank you so much. Bye-bye.
Thank you, madam. Thank you.
Thank you, Dr. Veena Bhatt, and thank you, Dr. Jyoti. Thank you so much.
Thank you, Preeti ma'am. Thank you, Vidya
Dr.
ma'am.
Rashmi.
Bye.
Dr. Vidya, how are you?
I'm little better. I got my MRI done. So they told to do some exercise and physiotherapy. So that is going on.
Madam, Vidya madam will teach you yoga. A few poses.
Yes. I'll join Veena Bhatt's yoga classes.
Sure, madam.
We will also join.
Yes.
Find out Vignesh. There's somebody called Vignesh Thirman. Find out from which facility.
Anyway, I'll be meeting Preeti and
I get a lot of
Safe
responses.
Motherhood Committee people in Hosur. I'm traveling there.
Yes.
Yes.
Have a safe trip. Have a
So
safe trip, ma'am.
we are
Yes,
conducting the
yes,
workshop
thank
on
you.
PPH on 7th
PPH.
at Hosur.
Yeah. Yes.
So our team is there for workshop.
I'll be there. I will join. But
Thank
I'll
you.
not join your workshop, but I'll meet you next day.
Okay.
Okay, thank you.
Thank you,
Thank
Vidya
you.
madam and others for the opportunity.
Thank you, Meeta. It was wonderful talk.
Thank you.
Thank you so much, ma'am.
Nivedita, as usual.
Thank you, Firoz.
निवेदिता को तो हर बार मैं congratulations करने से एक बार ही कर देती हूँ.
Thank you.
Thank you.
Bye.
Preeti ma'am, I'm ending the meeting for all.
Please end and please edit also before putting a